Dear doctors, wait for 2 minutes to start the class. Doctors, hello dear doctors, this is Dr. Shariar, your mentor. I hope so everyone is doing well, and I hope so you can hear me. So my best wishes to all the doctors, those are attending us live and those are attending the live class. Before we start, just want to hear from my dear doctors, is my screen is visible, is audio is loud and clear? So just want to know the beginning. Loud and clear, the sounds? All right. Okay, fantastic. Great, my dear doctor. So we're going to start in just 2 minutes because some of the live audience is also going to join with us. So there's two things I'll try to give you guidance today. One, of course, the respiratory recall. That's the reason, all of us are here today. And the second thing is it's very important to know about the books, which is related to ANC. I'll give you guys books tomorrow, so don't worry on that one. So this is your mentor, Dr. Sharier. So I'll be going with, my cam on today, so I don't mind on that thing. So it'll be so because you're going live, so that doesn't matter. So hello everyone. I hope so everyone is doing well. Am I visible along with my screen? Just want to be sure. I think. All right. So I think it's visible. I think. All right. No worries. So let's just see, like, how it happens, like just doing a little bit more experiments. All right. So, but you guys try to turn off your microphone by the time. All right. So here we go, my dear doctors. So this is Dr. Sharier. I'm been a tutor for last, it's my 10th year, I would say. And for AMC, I'm teaching since 2016. And this is our batch 31. So you can understand, so a lot of way we have gone through. And in today's class, we will be discussing respiratory recalls. At the same time, we'll be discussing about the books. As you can see, like, there's some book list you can see in our screen, actually. So before we start the class, let's give you guys a quick demonstration. And since a lot of doctors are still joining us one by one, let's wait for them for 1-2 minutes. By this time, if you have any inquiries, you can ask us in the comment section. Okay, so let's not waste time, and let's, I think, quickly get into the books thing, actually. All right. So about the books thing, okay, so it's a nice animated thing, as you guys can see. All right, yes. So I'm currently in Australia, and yes, this is a certain things about the books, as you guys can see. So, my dear doctors, about the books. Let me turn off myself first. It would be distracting a little bit. I'll come back again. All right, so let's focus a little bit about the books thing here. So before I start, let me zoom in this place. So because we started the class, but directly I didn't talk that much about the books. As you can see, like the first book, which is so important, John Murtagh. So we have John Murtagh currently suggested to use 7th edition. Currently, we suggested to use the 7th edition. But if you have the 6th edition, we also try to tell the page numbers during the class, so you can also at least follow. After the lockdown is over, you can buy the 7th edition book. In local markets in Pakistan, Bangladesh, India, the books are available, and of course, it's available in Australia. Anyhow, if you order online in Australia, it will take around 10 days. Okay. eBay has available this John Murtagh book. Now, master the board, AMC handbook. Now, one of the logo, if you see AMC, these are their official books. So handbook, John Murtagh, technically you can say, and this one, anthropometry, anthropology. Now, out of this, the logo books actually, these two are very old. I mean, anthropology, anthropometry. In fact, AMC handbook is also a bit old nowadays. It's been last edition, I think, was released 9-10 years back. Okay, so but it's still AMC handbook, which is known as blue book, still we use a lot actually, because that book is so important. Apart from that, as you can see, John Murtagh is very, very important. Selective section, I would say word, selective section of John Murtagh is very, very important. Okay. Now, apart from that one, there is MC bestseller that's available only in Bangladesh, due to time issue and hassle sending the courier, like we stopped that one, but we have increased those information in the classes actually. So let's forget about that one. Then only Bangladeshi doctors can get it from the office or when the lockdown would be over. Another one, the red one is known as actually, this is something related to RECGP guideline, also known as Red Book. It has the 9th edition as well, so you can utilize that one. So all the screening thing, there's a topic which if you see in the class screening, so you can check the screening related topic from this part. Now, there are some of the other books related to Kaplan, but out of them, Kaplan psychiatry is most important. At least if you want to follow one directly, that would be Kaplan psychiatry. All right, medical ethics, there is a book, 100 Case of Medical Ethics. We are also publishing one, same like as our bestseller. I also have another publication, like it's related to MC surgery book. You can also check that one. So these are certain books, like the publication things. Okay, so these are little idea about the book thing actually, so which you can see. All right, so the red book one, don't worry, I'll upload the newer one, or my class monitor, they can also upload the new one. Okay, don't worry about that one. All right, so these are the certain few things. Let's go out from the Zoom. Okay, so still, yes, nice city, right? You'll be here someday. All right, so that's the thing about little bit thing information about the book. And okay, now let me come back again by turning. Am I visible, guys? Okay. All right. Now, if you see, my dear doctors, like ebooks, also there's a lot of ebooks available, as you can see. So in the ebooks thing, if you check, ebook thing, if you check, question bank, I'll tell you shortly. After finishing the ebooks thing, I'll tell you about the question bank. So John Murtak 7, John Murtak 6, the book, Master the Board, Ethics, Handbook, a lot of Kaplan things, psychiatry. So all the Kaplan series basically. But as I said, the one that is most important is the Kaplan psychiatry. Apart from that, you'll don't get confused with one of these options. Okay, let me zoom this part because some of the people, they are always using mobile. Patient education and John Murtak is not the same book. So patient education is basically we use for MC clinical. Say if you are going into the MC clinical exam hall and you get encountered with a patient. Now sometimes we have to use the layman's word. So those layman's word actually is, and sometimes the role player, they have some innocent questions actually. So what is it? What do you think? So those kind of patient education question, how you have to tell, is discussed in that book. So for MC1, I would say it's not that helpful, but MC clinical, it's that helpful. Okay, so I hope so that will clear that confusion. Medical ethics 100K is fantastic book, guys. Just read it, understand the concept. That's more than enough, I think. But sometimes understand one thing: ethics is very tough to just go with the recall. Actually, to be honest, you need a proper conception in case of ethics actually. And there are some other books, immunization book, asthma handbook. There's some additional book, but normally if you follow the classes, that will be more than enough. Now, preparation for MCQ, a good course. Many of you have already joined already. We're just about to shut down this batch actually. I mean, close the door and continue with this batch. And there is a rule of 5. Now I will tell you what is rule of 5. Now rule of 5 basically is something, if you just focus on the screen. Okay, I'll turn myself off now. Okay, so rule of 5 is something, anyone knows what is rule of 5? Sometime I tell in the class. Rule of 5 is something, your study should be 5 hours a day, 5 days a week, 5 days a week, and our course is for 5 months. So for 5 months. So this should be, dedicated. This particular thing should be dedicated. Very, very important. And, sometime if you remember, in the class, I also talk about some of the pillars, right? Some of the very, very important pillar or SMA tetrad: theory, recalls, mocks, question banks. Now coming to question bank, which question bank? Any question bank is okay. Official, there is no such official, but AMC bank is one, Amadex is another. These are some of the 2 useful question banks. Apart from that, people also use USMLE bank. Apart from that, you can also use Canadian bank. As an expert, some people ask, doctor, what do you suggest? I suggest pick up any of the one. Pick up any of the one, finish it properly. What is the way of practice? Another way of practice is you focus on the question banks, Those are corrected answers. I repeat, those are the corrected answers. Those things you don't need to repeat again. So those are the mistaken one. You should mark them. Okay, I will come back and see that one again. Why I made mistake. So you mark that one. So if you have printout, that's okay. If you don't have printout, you write the concept. That is more very, very important. All right. So this is one of the things. So a good course, rule of 5, theory, recall, mock, question bank. That's how we need to proceed actually. Okay. So this is the key to success. Now, if there is any question anyone wants to ask, about the, I'll give you floor. If anyone wants to ask about the books, I would love to answer. Yeah, but do not ask controversial things. Actually, is this better or that better? Especially question banks, because I'm a like expert level tutor. I don't want to get into the controversy. Actually, which one is better? Actually, any question banks are better. Okay. So anyone wants to ask anything in the group? I think it will be fine. All right. Anyone? Any questions? Okay. Soft copies I'll upload actually. Don't worry. Yes. Okay. Yes. At the end of the class today we'll upload the soft copy. Tomorrow we'll be uploading. Don't worry. Yes. Any question? Please ask the intelligent question. Of course, yeah. Please ask the intelligent question, not about the availability. Those I will tell you. Don't worry. Don't waste the time. Okay, guys. Like many are also attending in YouTube. Yes. If there any smart question to ask, please ask that one. From the old member, they can ask also to guide the new members. Okay. So not taking the questions. I think it's too early for, I think, the junior doctors. Okay. Now let's go and start our class. Why we are here for. Our class topic is respiratory. I think few updates I like to add along with the previous file. So some of the questions from the 2020 from the respiratory, which I'm going to discuss now. Understand one thing, the recall thing is not always complete. So the recall thing, you need to, you will get a cracked one. So you need to complete it. And you need to understand the differential at the same time. So let's go and see our first question for today. It was I think, incomplete one bit, while all he can remember, I mean, the recall can remember the pulse oximetry as initial listed. But see, this is so less information. So I try to just make it a little bit more complete. When we say that, pulse oximetry as a initial test or something, yes, a patient presented with in the chamber or even in the hospital, it is a very cool thing. We can very easily measure that one. Now, the recaller didn't mention, is it in a GP setting or is that in a hospital setting? That was not mentioned actually. But if it is GP setting, it's a very cool thing to, use the pulse oximetry, as you can see. Pulse oximetry is a very cool thing to use, especially just give me a second. Let me take the pen thing. Yeah. So it's a very, very interesting thing, the pulse oximetry, because you will get to know about the saturation. It is very, very important. Now, one of the question is coming that which saturation is life-threatening? Like, I personally have a feeling this is a dyspneic patient which is presenting in the GP setting. Okay. And you are the doctor, which initial test you can do in the GP. So pulse oximetry, it is usually available in the GP setting, and you can very clearly do that. Now, pulse oximetry, when you do that, and you are finding it is 98%. Now, do you think 98%, should I send the patient to hospital? Any idea? Which one do you think it can be life-threatening? Which, parameter do you think it can be a life-threatening for this type of case? The answer is 92. It should be like 92. So below 92, that's how it's given. The below 92, it's a real warning sign. Last day there was theory class, I showed that one, but below 92, it's really large. Now some of the doctors are telling 85. I'm clearing that confusion. Below 85, Below 85, it is actually even more serious issue. Now below 92 can go to hospital, you can give oxygen and the other measurement ABC, patient can be fine. Below 85, do you think just giving oxygen, will that be enough? I repeat the question, below 85, do you think if you just give oxygen, that would be enough? The answer is probably no. We know we need something more. The patient is dying here. So it's better we start something which we called very commonly intubation and this kind of thing, or better to say CPAP. Now a commonly asked question, doctor, to choose intubation or I can choose CPAP. CPAP is better, all right? So it's better when you find the both option. There is also MC handbook question similar that, like CPAP and intubation both were given, but at that time, CPAP was chosen. Okay, so what is CPAP? It is a non-invasive, okay, non-invasive type of ventilation. Actually, we'll see that very soon. And more questions will coming on that one. So there's a non-invasive ventilation. It is better than intubation. Okay, please remember this thing. And about pulse oximetry, it is given as you can see, since I just the 98 normally is a serious sign. And in that case, ABG check. Now, one extra thing is coming, my dear doctors. Now, if you find with pulse oximetry, if I just make a new question, and if I give it like that, so pulse oximetry was done, saturation is below 95%. Now, what to do next? If I just make a question, what to do next? Or which investigation is the priority here? Sats is dropped. So in that case, my answer would be, my dear doctors, ABG. I repeat, in that case, things would be ABG. Well done. Okay. So that is one of the thing. Spirometry, my dear doctors, already I think I have cleared FEV1 by FVC, but some of the doctors are attending for the first time. For them, I'm telling FEV1 by FVC. This is something done, like to rule out something obstructive lung disease or the restrictive lung disease. Now I do FEV1 by FVC. I'm talking according to John Murtagh. It was given in John Murtagh 75%. FEV1 by FVC. When I do this ratio in the lung function test, below 75 indicating what? Obstructive lung disease. Now, obstructive lung disease indicating asthma, obstructive lung disease indicating also COPD. Now, how do I understand? Both cases, it will be less than 75. Now, how do I understand that my case is asthma or my case is COPD? Yes, the answer would be in this case, there is a special test to differentiate asthma versus COPD. And what is that one? Post bronchodilator test. Post bronchodilator. Some people will also tell about methacholine test, but in our day-to-day practice, we usually use the post bronchodilator test. So post bronchodilator, if you say, the idea is similar. So what do we use there? Basically, we use there SABA. Have you heard this name? Yes, S for short acting. So short acting beta agonist. This is a drug which is just used for bronchodilation. Remember the definition in case of asthma. It is a narrowing of the airway. So do you think in case of asthma, say if you do FEV1 and FVC, in asthma case, it is 72%. In COPD case, it is also 72%. Now, after giving post bronchodilator, what response you are expecting? 7%, 10%, 15% minimum. So in case of asthma, there will be a 15% improvement, my dear doctors. So 15%, that is indicating, yes, it can be 15% or more, better to say. It can be 20% as well. So more than 15%, if there is improvement, that is asthma. In case of COPD, the improvement would be like much less than 15%, could be a 2 to 3% improvement. And that will help differentiating from the test point of view, asthma and COPD. Very well done. I can see the chat box. Many are answering very well. All right. So see, from the first question, we jumped into another place. This picture was taken from Oxford Medicine. All right. Next question. Let's see. Next question. All right. Taking up that one. Yes. Next question. X-ray was given. Left side was clear. Right side looks like pneumonia. Now these are Recaller's word. So in the main exam, they might actually give you an X-ray, which might be have a little consolidation thing. So in this way, it is not will be told in the main exam. It is just the Recaller's word actually. So right-sided looks like pneumonia. Patient producing yellow sputum. So our keyword for today is yellow sputum for 3 days and not improving with antibiotic. Now, my first question is sputum for 3 days. Can we suspect lung cancer, tuberculosis, this kind of thing, or even pertussis for 3 days? Answer would be a no. So let's remove that thing. Say example, carcinoma of the lung is removed. Mesothelium is also removed. Also, this kind of situations also have some constitutional symptom of cancer, which is not present here. So two of the things that is remaining in here, one of them is a lobar pneumonia. One of them is aspirational pneumonia. Now, I didn't see anything like hospitalization and things are given. So what do you think? If you think as in a common way, that case, the answer would be lobar pneumonia. Unless it is mentioned hospital admission, hospital visit, you are a visitor, this kind of thing. I don't think so. Or, you are an ICU patient or something like that. So I don't think so. It's a B, but I do think this can be an answer. All right. So my answer for the next one, I choose A. It's a 2020 question, my dear doctors. Next question. Post-op cases. I repeat, in my case, post-op cases, post-operative patient actually, and in less than 24 hours, you see this one, less than 24 hours, develop shortness of breath, and the patient is having fever. Now, what is your next step of management? Any idea? Chest physiotherapy, drainage, or maybe antibiotic? What thing as a diagnosis is coming to your mind? What thing as a diagnosis is coming to your mind? Do you think that is a case of atelectasis? Now, I'll clear this doubt to all my dear doctors. Okay. I'll clear the doubt in a moment. Is it visible? I think not very clear. Okay. Now, below 24 hours. Now, this question, don't go with the answer which I put. The recaller said the fever, he is not very sure. Okay. This thing he said he is not very sure. Now, I need this information very badly. Now, in the day one, if we are saying post-operative fever, day one. So one of the 5W, wind, water, walking, own, and wander. I repeat, wind, water, walking, own, wander. 1 to 2 wind, 3 to 5 water, 5 to 7 walking, and the day 7, it can be wound. I mean, the wound infection, typical. You did an appendectomy, after 7 days, there is some discharge. This is a wound infection. Even after that, there could be deep tissue abscess. That's a different thing, a very uncommon in the exams. Now, wind cases, I found two things. One is atelectasis and one is post-operative pneumonia. You see this one? Now, how do I get to know which one is atelectasis? It's very clear by doing a simple X-ray. X-ray will tell us whether it is a atelectasis or whether it is a pneumonia. Another way to figure out is fever. In case of pneumonia, the fever would be quite high fever. But unfortunately, in our case, it was not mentioned, like, the recaller was not full show, whether there was fever or not. But we do have another information. There was shortness of breath. We do have another information. There was shortness of breath. Now, with that information, let's just make the puzzles. So if there is breathing problem, breathlessness is one thing. plus the fever, if not so high, not so high. Now, what is your diagnosis? If I say breathlessness, if I say below 24 hour, and if I say fever is not so high. So my dear doctors, I think my diagnosis would be atelectasis. And if atelectasis is the diagnosis, what is the management? Now, if you come here in this area, the therapy prevented by incentive spirometry and all these things, or chest physiotherapy, whatever you say, chest physio, this can be one of the option. Another option, it can be chest physio, one of the option it can be. Another option, it can be like just a synonym, incentive spirometry, incentive spiro. This is one of the puzzle. Another puzzle, same thing, shortness of breath plus cough and high fever. High fever. Now you tell me your diagnosis. I didn't give you the X-ray. If I give you X-ray, it would be even more clear. X-ray showing consolidation in the middle lobe. Now this is a case of pneumonia. Is that correct? If it is pneumonia, I think even it's more clear. Depending on mild, moderate, severe, we give the treatment, isn't it? So I hope so. It will be, helping this information. Just don't always go with the recall. Just be with the concept. That's very, very important actually. So there are a few other W's which we will be talking in the surgery more, but wind, water, walking. This walking in 3 to 5 days can be urinary tract infection. So we need to do an urine analysis. 5 to 7. Remember one thing, after surgery, development of shortness of breath on the day 5. After surgery, on the day 5, development of shortness of breath. This is another popular AMC question. I think surgical question though. So what do you think? When you examine, the patient has a swelling on the calf of the leg. So shortness of breath, there's a swelling on the calf of the leg. My diagnosis is pulmonary embolism. Clear that one? And believe me, from pulmonary embolism, there will be so many questions will be tested from pulmonary embolism. What is the initial test of pulmonary embolism, my dear doctors? Does anyone have idea? It is initial test. No doubt that is X-ray. And what X-ray is showing? Often they tell in the exam, wedge shape opacity. I hope so you're writing. It is showing wedge shape opacity. Next one, initial, then next. What is next in case of pulmonary embolism? Now, two things are coming. D-dimer. One is D-dimer, another is VQ scan. D-dimer and VQ scan. And another, lastly, confirm. How to confirm a case of pulmonary embolism? To confirm pulmonary embolism is CTPA. That's a kind of like a CT scan way. So CT pulmonary angiogram. CTPA, very simple. Now there will be more questions which I will be clearing in coming days. If the patient presented with pregnancy, what to do as a next? If patient presented with renal impairment, what to do? This is another vital question which we will cover in the surgery, don't worry. So I just like to move forward from here because we need to cover a lot of things. Now, next question is coming. Next question is coming. On the emergency department, 15% pneumothorax, no chest symptom. No chest symptom, very clearly states no chest symptom. So what do you do next? Now, normally what we learn from the pneumothorax in John Murtagh. Now, this is the part where Murtagh will play a part. We were expecting the word observation, but sometimes this is the twist in MC. In this question, they didn't offer you the observation, but they do offer you an alternative to observation. That is a re-X-ray. So I think the best possible answer is this one. Best possible answer is this one. Now, what you are thinking, doctor, why not you are suggesting it is a case of pneumothorax and you are not suggesting, needle drainage or something like that. Now, let's come to this one. Okay, I'm going to open my video again. Am I visible, guys? I'm not sure. Am I visible or not? All right. Just want to say hello to all. Okay. All right. No worries. Let me stay for a while. It's good for something engagement. All right. And I'm giving effort. It's sometimes also shown actually. That's okay. Okay. So in case of pneumothorax, if you see pneumothorax, pneumo, that's air. So air in the pleural cavity, that's the pneumothorax thing. And as you can see, one thing is if less than 25%, less than 25% means like this, less than 25, 15 is less than 25, and no chest syndrome supposed to be observation, but observation was not in the option. So in this case, we are going to choose re-X-ray. Now, sometimes I tell a word, compare and contrast. What is compare and contrast? Compare and contrast is kind of like, similar type of thing. Uh, like same like this, re-X-ray. Can you tell me any orthopedics condition where we have to do the re-X-ray? I think the previous batch students, they definitely can, I'm sure. We remember like some of the hand joint that has been fractured, and after 15 days we again do the re-X-ray. Example Collis, example scaphoid. Two very, very important topic in ANC, right? So remember, just so compare and contrast is always helps us to remember. So brain boosting is very, very important. So compare and contrast. So this is another thing to remember actually. So Collis, I was saying Collis, I was saying scaphoid. So after doing the close reduction, I mean all the thing you do close reduction, and when you send the patient just to see whether things are going fine, we do a re-X-ray. So similar re-X-ray. Here is after 1 day, and in that case, usually after 2 weeks, right? That's the difference. But anyways, like let's go for the next one. I hope so you understand it. It's not a very tough one after you finish the Jomothai. A case about pneumonia in a 7 month. 7 month, I think it's, you can understand, very small. No diarrhea. What is the organism that is suspected? Last day we are talking about something about the organism, if you can remember. So I show you a very nice chart, and which one you should think now? Is it the respiratory syncytial virus? Is it the other thing? Which one do you suspect? So less than 1 year, yes, my dear doctors, if it is less than 1 year, as like same like the rota, remember like the kid is having diarrhea, we also think about the rotavirus in that case. So same kids having respiratory symptom and all this thing, it can be, yes, possibility respiratory syncytial virus. Yes. Now, from where I'm telling this one, there's a chart last day I showed whether it was given age-wise distribution actually. Now, some doctors telling bronchiolitis. Yes, that's a very good differential. Respiratory syncytial virus also very common in bronchiolitis because it is within the 1 year. So someone who said bronchiolitis, technically correct, but to establish a case of bronchiolitis, you need to have certain feature. One key thing, please write, my dear doctors, tracheal tag. I repeat, tracheal tag. You need to write that one. Okay. There will be a history of, this viral infection 7 days back. So a prodromal of viral infection that will be present. Prodrome of viral infection that will be present. All right. So this is another thing, and yes, also about the fever. So what do you expect? Like, fever would be tracheal tag, TUG tag. Okay, and another thing, what do you expect about the fever? Should it be virus? So do you think virus is high rate or virus is, do you think so those are telling about the virus, is it a high rate or low grade? Yes, it is supposed to be low grade. All right. Now, in the main exam, that might be helpful, right? If, I repeat, if the fever is given very high, you might be thinking about sometimes even strep pneumonia, but if not, it can be thinking about the respiratory syncytial virus. So bacterial, the fever is very high. In the virus, usually not very high. Usually, use the word usually, always it's safe actually. Sometimes you see like the professor, they get angry because you don't use the word usually. Anything can happen, right, in the medical system. Next one, it is coming. So our final answer is respiratory syncytial virus for this one. And more reference, you can see the last day chart. 17-year Caucasian girl is came from China, lymphadenopathy, fever, sore throat, and what's your probable diagnosis? As you can see in the screen, what do you think, my dear doctors? I can see from the box, people are responding. So everyone is answering, Everyone is answering one thing. Yes, this is, Epstein-Barr virus. Now, one more thing, if you can tell everyone, that in case of respiratory syncytial, okay, that's the last one, Epstein-Barr virus, one cancer that can be associated with Epstein-Barr virus. One cancer in adolescent or even child, that can be, okay, lymphoma, agreed with lymphoma. Another thing else, yes, nasopharyngeal carcinoma, lymphoma and nasopharyngeal carcinoma, to remember. Now you see this thing, so posterior, that side lymph node when I'm talking about, so automatically, so nasopharyngeal, these names are coming. And I also bring this one as a, so I'm just highlighting a little bit, those some of them are mobile user. I always tell them, please guys, use a laptop, for God's sake. But it's still, they always try to come. Another day, the thing happened very funny. One doctor was, sleeping in the bed, like this, and wearing a, sando genji or something like that. And, also like, putting finger in the air, I don't know, he was attending class or not. But guys, if your position is like that, do understand, I have a option here, I can turn on your video actually. Okay, so just be careful sometime. Okay, so just sit in a proper way, in a proper place. I'm sitting, so expecting you are sitting too. Okay, so you see this one with the nasopharyngeal carcinoma, the China name is coming actually. That time when I think many of you know, I was also in China in 2013 to 15. So that time I also used to know that, like, so which diseases are quite common in China. So one of them is that Epstein-Barr virus was quite common. But nowadays, like the corona and all of these names are coming, but there are a lot of other geographical things out there. One of them was Epstein-Barr virus. Another one was herpes actually. Another one was herpes actually. Yes. Yes. Do you know when coronavirus was the last time it was, I think, even it was big actually. Coronavirus actually, if you see in the Oxford Handbook 10th edition, there was a separate chart given about coronavirus. So it was, yes, like 2002, I think 2004 it was given there actually. The SARS comes as a SARS. So that's also under the headline of corona as well. So it changes its pattern and just, keep growing actually. Now it's become more powerful actually. I hope so the things will be good actually. It's good already in the Australia. I think one of the country along with Finland, Norway, Australia, Taiwan. I think a lot of countries has done very good job actually. Yes, New Zealand, yes, of course, New Zealand. Yeah, right. So moving forward to next one. Okay, like there is a little bit thing I brought for you guys to see this one about the Epstein-Barr virus. Yeah, sad to see in my country, Bangladesh situation. I stopped seeing the news, guys. It's making me sad. Every day, 50, 100, 50, 100 increasing. I'm feeling really sad. I'm also stuck here in Australia. Anyways, couldn't go back actually. Now, Epstein-Barr virus, you see, young disease is also known as a very popular term. Kissing disease is okay. Um, in adolescent probably is common in that time. So fever, uh, lymph node enlargement, and one of the word I highlighted, atypical lymphocyte. And when you do the test, there's some tests which is called positive monocyte, positive monospot test, positive monospot test, initially to start it with. But when you confirm, there will be more other tests actually. So this is not coming. This is we will be discussing in separate place, which test is initial for Epstein, and which test to confirmatory for Epstein. These are different. Right. So for now, please remember these terms actually. It would be useful for all of you. Moving forward to next one. Right. Okay, this make it a little easier for you. Child 3 years old and cough and yellow sputum for 3 weeks. Now this is changed a little bit, 3 weeks. No response for antibiotic X-rays given, and white patch in the upper lobe of the right lung. Now what do you expect? What is yellow sputum? We expect actually yellow sputum for shorter week. Yellow sputum is a sign of infection, isn't it? Yellow sputum usually it's a sign of infection. So what do we expect? There's so many name of pneumonia are given. Is it in typical pneumonia or does it looks like a complication of pneumonia? If it looks in like a complication of pneumonia, that can be emphysema. Please do consider. Now it is taking us to one of the point. What is the one of the commonest complication of pneumonia? The answer is emphyema. Emphyema is the one of the commonest complication in case of pneumonia. But anyways, among the common things there is lobar, but I don't want to go with lobar. Lobar is very common. Previously we saw just 3 days, suddenly, breathing issues and things. That was the typical lobar pneumonia. Mesothelioma, I don't think so, because there was no hemoptysis thing. There was nothing mentioned about what occupation. What occupation we look for in case of mesothelioma? Everyone, last day I told about that one in the theory class. Today we are going to recall class because we have done the theory class already. We talk about asbestos exposure, but that's not the main thing. Occupation means plumber, basically. Like someone is doing welding, plumbing, dockyard. Yes, so those are the things. So those things were important here. So this is nowhere the answer. So mesothelioma is out, lobar is it out. Now lung cancer, I'm expecting constitutional feature of cancer or paraneoplastic feature. I think those of you are just medical student are attending, you can just check like, uh, paraneoplastic feature of lung cancer. So nothing is mentioned, nothing mentioned about also weight loss or something. So it can't be uh, lung cancer either. So we have two options left: aspiration pneumonia, and one option remaining, emphysema. This is the thing. Now, what do you think? To establish a case of aspiration pneumonia, where you are expecting the patient is to be? Yeah, someone said is a nice thing in the group. See, in our country, you see, okay, every parent want, okay, my boy would be a doctor, my son would be engineer, and something like that. In this country, unless someone is an Asian, they don't have this kind of thing. Okay, here the thing are mostly about enjoying life and earning, number of money that comes. Do you know a truck driver earns much more sometimes than an IT expert? Do you know that? In Australia, actually. A truck driver, I mean, those are, driving the big trucks. Yeah, but you don't expect that one, back in Asian countries, actually. Much, much higher, actually. Yeah. So that's the thing, actually. So yes, heavy drivers, actually, yes, those running the big ones. Yeah. So they earn a lot, actually. Yes. Anyways, guys, so we are here to fulfill our dream for Australia AMC thing. In this one, I choose my answer. Let's go for this one. In this one, where is that? Okay. So in this one, if you see, like, since it was mentioned 3 weeks, it was mentioned 3 weeks. So I would like to change that answer, I guess so. The lobar pneumonia one. So lobar one, I think I would like to go with the more early one, the previous one, early onset one. Okay. And since it's not happening, maybe it's the complications. So I would like to just change the answer. I'd like to go with the E as an answer. It's very close, actually, lobar, but lobar also has a similar question. If you have seen, the problem was for 3 days or 5 days or 7 days. So early onset. So maybe he suffered and then having a complication, emphysema. So that's all I think, actually, here. All right. Do you have any question, doctor, like regarding this one? I can answer this one. Little close, actually. Okay, someone said, "Oh, not aspiration." Aspiration, we are expecting the patient, probably expecting in hospital setting, uh, also in ICU, and all these things are expecting. Now I don't know if the recaller has missed that part or not. This is one of the thing. So it can be possible, like in that way. But aspiration pneumonia, if you are thinking about the typical question, we are expecting those words. Yes. Lobar is a close one. Someone asked, like, why not lobar? Lobar at least is a close one. But you see, like, 3 weeks passed. Normally, in the within the 7 days, the pneumonia symptom and typical these things, we figure out, actually. That is the thing. Okay. All right. One more thing we can add here sometime is, yes, like in case of pneumonia, sometime the word that was actually contradicting is actually the lobe of the lung. Yes. So in case of the lobe of the lung, sometime emphysema, there was another typical question, but nowadays we saw changing patterns. So emphysema, we were expecting it's in the lower lobe, moreover in the lower lobe. That's the so but see, these are medical theory and thing, not always the same formula works. Every year they came up with changing question. We always saw that. All right. So if you think in this question, I think as a common one, I also answered that one as a common one, lobar pneumonia, that was fine, the answer. But since it was 3 week, so I thought like, okay, it can be a complication. Okay. And maybe you see, this is just a one line given. So maybe one of the point could be missing here actually. Okay. So normally the questions are not one line, it can be 3 or 4 line, right? So that's the thing. All right, and I wish we had the X-ray thing could have been much more clear. If the X-ray would have been clear, no, we wouldn't have fighting actually, to be honest. If we would have the X-ray, we wouldn't have fighting actually. If it's typical pneumonia, I think the middle lobe or any other consolidation, typical one. If typical emphyema is the lower portion will be more affected, that's expected. Okay, so when you get the X-ray, I think for this question, let's leave it for the X-ray, right? I think let's not battle actually because we don't have the typical X-ray. When you have the typical X-ray, I think it will be much clearer to us. All right, so that's the thing. Next one, middle-aged female with sharp left chest pain, and shortness of breath and pain in the both thighs on examination, visible staple inspiratory wheeze on the left lower side, tenderness of the thigh and extension in the middle lobe, heaviness. What to do next? Okay, quite a big one, right? So don't worry, I think will be fine. So middle-aged female, sharp pain in the chest, like that can be chest pain can be two types. One central, the peripheral. It looks like a peripheral. Peripheral thing again, think as respiratory. Okay, now you think, well, what are the key findings? There is wheeze present, and lower zone, some haziness and thing you can see. So what is the next thing we should look forward actually? So I think it's very clear cut. Many of the respiratory cases, see, we started with X-ray, then we go with the CT. Then if it is either a cancer or this type of suspicious cases, then we go for biopsy. Okay, so I think obvious reason, I think our answer here would be X-ray expected. I mean CT scan here. So we pick up the CT scan here. Now here again, a thing is coming, compare and contrast, similar like that. So tell me some of the respiratory disease which I have taught, why we started with X-ray, then we went for the CT scan as a next, and then we went for biopsy as for final confirmation. So what were some of the diseases which I have taught like similar like that? So one of them was sarcoidosis, another one was the mesothelioma. So sarcoid, mesothelioma, some cases lung cancer as well. Yes, lung cancer as well. Okay, so the cancer and the sarcoid actually. Some said pancreas, yeah, that's also lung cancer actually. Yes. So going for CT is a good answer here. Well done. Another controversial, and you see that question you were looking for, the puff one is coming here right now. So the baby, 6 months baby, fever, cough, respiratory rate 40, and saturation is such, you see this, chest is silent, and the tube of salbutamol, 6 puff was given 4 hourly and no relief. Okay, now what to do next? That's given here like that. Please mark the age of the baby, which is very, very important for us here. This one I try to teach last day, in our asthma chapter in John Murtagh. So I hope so you remember that one. So if we saw that one from that particular chart, yes, this is the chart I was talking about, taken from the John Murtagh. So if less than 6 years, what is our age in this case? In our case, 6 months. 6 months means less than 6 years, definitely. Okay. So in this case, actually, initially you have to give the treatment which is necessary. Okay, someone is saying, okay, silent chest and other thing, you don't have the other options given. So if the things are given like you initially follow the protocol, this will not take that much time. You follow the protocol, then you jump to the other. Okay, you might get the response even in that case actually. Now, it was mentioned about the 6 puff, and later you can also go for the 12 puff if actually 6 year or more than 6 year actually. There was another popular question, if you can remember, whether to give 6 puff, whether to give 12 puff. because that child was 6 years of age, initially it was given 6 puff, and they were asking what to do next. So if it would have been that question, 6 year, the next would be 12 puff of salbutamol. But it was mentioned in the question. Here, nothing was mentioned like that. In this case, it was just a 6-month kid. It was just a 6-month kid. And here the options are given. Initially it was done. Initially, Saba was given, salbutamol was given. Now they're asking about the next. And you have two options now in the next. One, salbutamol 2 hourly. Now my first question is coming, salbutamol 2 hourly, is it justifiable? Or the 2 hourly, ipratropium is more justifiable? So I like to say, I think if you see here, I think IPRA, this is more justifiable because both options are given here. So now let's see the answer again. So ipratropium 2 hourly as a next, because initially started with 6, his age is 6 months. 6 months means less than 6 years. So since less than 6 years, so either of the option. 6 puff salbutamol. What was would have been a perfect answer? If I just cut this one and if I just ask 6 hourly, then I think this is better answer. We like to stay with salbutamol, or do you like to stay with the ipratropium? What do you think? Which drug is more safer, salbutamol or ipratropium? Ipratropium is a narrow therapeutic index drug, isn't it? So we should not always use the, ipratropium all the time. Actually, if possible, finish the case with salbutamol. But unfortunately, the salbutamol things are given. It's not proper, I think. So we choose the ipratropium here too. Okay, so my answer was here is B. Now there is a question coming, as you can see. Refugee, 8 kg, and weight loss history, hemoptysis, chest extravia atypical changes, also had leg lesion. How to diagnose the condition? What do you think? Anyone? All right. So the refugee, this one, like I think last day's discussion topic, as you can remember, I turn off my video, so don't worry. Okay. So refugee means immigrant, can I say? Remember that day? Okay. Refugee, somehow, if we remember, it's an immigrant. Clear? Okay. Now, refugee with hemoptysis, X-ray changes on the apical changes they mentioned, and some leg lesion, that's okay. How to diagnose that condition actually? Already mentioned about X-ray change, already mentioned about hemoptysis, mentioned about weight loss. What to do next? My first question, last day's chart, you have to remember, last day's chart, RA CGP, there was a chart about latent TB. First question is coming, is that a symptomatic case? Is that a asymptomatic case? So according to that chart, which we are talking last day, yes, my dear doctors, this is the chart. Okay, so this is the chart. Yeah, I'm back again. Okay, so this is the chart you can see. So active and the latent. I think very clear, guys, like weight loss is there, hemoptysis is there. So all things are there. This is a symptomatic case. Okay, if it is a symptomatic case, we need to be sure. So since they're offering sputum here, as you can see, sputum, I think we should go with sputum for AFP. Clear, guys? We should go with sputum for AFP. Okay. Yes, those thinking about the biopsy of the leg lesion, that's coming later. Your first job is to confirm whether TB or not. How to confirm? You need the sputum. Very clear. Okay. X-ray showing lobar changes. Next question. And horizontal fissure not responding to antibody. Again, the yellowish sputum and hemoptysis. What is your diagnosis? Not responding to antibiotic. Days are not mentioned. Age, I would say a middle age. Let's say age, I would say a middle age. So two of the option, yellowish sputum and hemoptysis. Yellowish sputum indicating infection. And hemoptysis, you need to remember what are the causes of hemoptysis. Now, tuberculosis is a cause. Then there are more other causes, like bronchitis even is a cause. Lung cancer even is a cause. All right, but here they're not mentioning in big way about the cough and these things, and no constitutional feature of cancer. Another thing, nothing mentioned about constitutional feature of cancer. I personally think some of the information maybe could have been better. I think from the recaller side, definitely this question would have third and fourth line, definitely. But from the limited information, yellowish sputum infection, hemoptysis, we just think about bronchitis, but without any X-ray, without any CT, it is not possible to tell 100%. At least we need an X-ray at least. Okay, so at this point, sarcoidosis is a multi-system disease. They are not highlighting anything multi-system. So I'm using a method. It is called now exclusion method. So sarcoid is out. Okay, sarcoid written 2 times. Another one was written, I think, mesothelioma. Another, I think, was written was mesothelioma. Mesothelioma is nowhere as well. Mesothelioma often presented with pleural effusion. Often they are plumbers, so those are not mentioned. And lastly, there was chronic. There is bronchiectasis. Now that may be possible. Yellow sputum and infection so common. Infection is so common. It's in case of bronchiectasis, and hemoptysis is also a feature. So my answer for this case, I like to go with the bronchiectasis. So yellow in sputum is a sign of infection. In case of bronchiectasis, it is very, very common. So bronchiectasis, few of the keywords. Bronchiectasis can be sometimes associated with CF, cystic fibrosis, which you will be taught very details. This has 5-star topic in EMC, will be taught in pediatrics. All right. So, and we are also expecting cough here as like other conditions, but we have a feeling that some words or points can be missing from here. Okay. And it's vice versa, because if you have bronchiectasis, it can be presented with pneumonia, this kind of feature as well. Information given, antibiotic you need to give. You need to be careful about the pseudomonas. Rest of the thing are bronchodilator, antibiotic, steroid, surgery if localized. But anyways, these are the maximum information. Okay. Now we have a question. COPD patient comes with shortness of breath. I repeat, COPD patient comes with shortness of breath and oxygen given by ventricular mass saturation is 69 now. This is 7.3, and ask about the management. Now, from the question, we can see it's not looking like a very complete one, but we do have one information. Partial pressure of carbon dioxide high, oxygen is low. Now, it brings us to a point. Is it a type 1 respiratory failure or type 2 respiratory? This information I can tell you clearly. That is it a type 1 respiratory failure or type 2? What is the criteria of type 2 respiratory failure? Both case type 1, type 2, hypoxemia is common. Saturation will be low. But in type 2, one feature is common, that is partial pressure or the hypercapnia, the carbon dioxide level is high. So if that one is there, so I think the best answer is probably here is, what do you think? Which one to go with here? We would like to go with the intubation. Now we have two nice options, I would say. intubation and the CPAP. So which one you want to go with, intubation or the CPAP? Now I'd like to show you something about the oxygen. By this time you guys can answer. Yep. Now you see this one, my dear doctors, about something about the oxygen, very nice reference. So about the oxygen, if you see hypoxia, like this is a range. Okay, very limited. So, another time I asked you, like, in the GP center by pulse oximetry. So guys, those of you who are practicing, I know it's initial little pricey that you buy a pulse oximetry, but cheaper one is also available. But if you are a general practitioner, do have a pulse oximeter at your, should be in front of your desk. Very, very important. So I said 98%, no need to send to hospital. You just still give him like, okay, you take a little nebulizer or a spacer. Last day, remember, nebulizer or spacer, which one is more efficient or equal? Nebulizer or spacer? Level on efficacy. Both are, same, both are same efficacy. And now in Corona days, which one is more preferable, spacer or nebulizer? Answer is spacer is more preferable because the same nebulizer using and a respiratory patient, it's high chance of contamination. So please, bring that awareness to the respiratory patients that, you should try to use the spacer more actually. And they're in more risk where they're using steroid and many other type of drugs. So they're in more risk, the respiratory patients. So 91 to 94, probably the simple mask and this thing, the oxygen, 86 to 90, Venturi mask. These are the methods. But you see this one, 85 or less, non-invasive ventilation, among them, CPAP is better. CPAP. Right? So that is the thing. Yes. So CPAP is more preferable. That was the answer I was looking for. So I like to go with CPAP here. Okay. Now compare and contrast. I hope so I'm not confusing or I'm not making bored with the word compare and contrast. Again, I came with my compare and contrast again. Okay. So in the compare and contrast, like I'm choosing CPAP over intubation. Now, for new doctors, it is little tough to tell. Some of the doctors we also have, they were in the previous batch and recontinuing again. So they can tell like CPAP, we are choosing over the intubation in there was another condition. Which one was that? That was taught in emergency and in orthopedics. So can anyone tell if both options given, we can also choose. Yes, so some of you start answering, yes, flail chest, where the ribs are broken into two pieces actually, yes, and the paradoxical breathing, right? And extreme pain, flail chest, number one treatment. Okay, what is the number one treatment in flail chest? Chest drain, painkiller. What is the number one treatment in flail chest? Chest drain or painkiller? Painkiller. You're in tremendous pain. Okay, so if they stay in, it's actually better to say in a stable patient, painkiller actually. Unstable or breathing become compromised, do not wait, do not waste time, directly go into the intubation or CPAP. All right. I hope so the explanation is clear. I hope so. Is it? I hope so. It's possible, right? Those are, listening first time, just for information, we have taught our students to theory classes first, and then we came to the this one actually. So that's why they are answering first actually. Okay, and some of the doctors are already very knowledgeable. I can see that. This is one of the question, which was very confusing. I saw in groups. What do you think? My first question. Those of you know a bit about acidosis and alkalosis, is this question looks correct? What do you think? With this range, can I establish? Okay. Now let's see, and another. Now it should be like this. It should be a few things like this, like Another point, like at least you need the oxygen, the carbon dioxide, bicarbonate. You can get the pH from the bicarbonate. You can gauge, right? pH you can gauge from the bicarbonate. All right, so now the ranges are there. Yes. Now, what do you think? Yes. So now I think, should it be like, hyperventilation? An asthma patient is what? Hyper, like I make you a very simple thing, hyperventilation. Hyperventilation. Now, in case of hyperventilation, what is expected? Two things are expected, isn't it? One, metabolic acidosis. Another one is respiratory alkalosis. Metabolic acidosis and respiratory alkalosis. Okay. So this is the thing which I believe. So acid base, we this season I think I have some also new teachers and things, but don't worry, I take the 99% classes actually. For acid base, I also have a good teacher, like I'll call him as well. So he's interested to take the acid base one actually. Okay, so so this respiratory alkalosis with compensation, D is a better answer here. So we'll go for more explanation on that one in future. Don't worry. But it's just we're just finishing the 2020 question first of all. Yes. Now, children with lower abdominal pain, fever, extra showing patch on the right lower lobe. What is the most likely organism? Now, child, unfortunately, age is not mentioned. Let's say more than 1 year, since it is said child. Strep pneumoniae, Klebsiella. Best answer would have been what? If I ask you just directly, name one organism, don't see at the options. What do you think about the best option? Do you think in case of children, strep is so common? Or do you think mycoplasma could be more common? Now, I have to take you here again. Guys, that's what I'm saying. You need to also put some more emphasis on the memory. Remember, in the infants, the popular mnemonic bell, beta hemolytic streptococcus, E. coli, Listeria, bell. Next one is the children. Yes, so virus and also the mycoplasma. So if you go and grow up, then you think about the adult and these things are more. Streptoneumony always can be an answer when it comes in terms of the adults. When it comes in terms of the adults. Yes. All right. Very, very important. Wonderful. So let's go back. So this one, I think the classic answer, it could be the classic answer. Best answer could have been, to me, could be mycoplasma. See, mycoplasma is not an option. Let's go for this one, strep pneumoniae. Strep pneumoniae, always common. Guys, these are the tricky things in the exam. These certain things you just need to know the tricks actually. Some people overthink in the exam. Some people underthink in the exam. It is just about practice. So more you will do practice, things will be better. More you discuss with the study partner, more you will remember. You should use mnemonic to understand or remember things more. You should make also small notes, sticky notes and things. Those are also useful in memorizing. Okay, so we'll be starting our things. I think we can take 5 minutes. Today's class could be a little longer. Don't worry, like those are our students, and they will get separate backup. So don't worry on that one. Actually, yes, because in Bangladesh and some other countries could be start time, but since we also involved the 2021, so the class can be a little longer compared to the other days. So we'll take a 5 minutes break here, my dear doctor. So don't go away. So we'll be come back in 5 minutes. Thank you so much. And those doctor want to ask me something, you can ask by unmuting. I don't mind. I'm available. Your buttons are on now of Zoom. So if you want to ask something, feel free to ask. Anyone wants to ask me something, please unmute and ask your question. Thank you. We appreciate more asking in class. Feel free to ask. Recall file is already uploaded in the group. Please check it. We appreciate. I hope so you're writing and things. Yes. Okay. Someone wants to unmute. Okay. Okay. Now it's okay. Yeah. Now I think you can unmute yourself. Yes. One doctor want to ask something.
Hello, Dr. Shahyar.
Yes, doctor. Hi.
Can you hear me?
Yes, very clear and loud. Just your name, please, doctor.
Okay, I'm Dr. Hafsa here.
Okay, Dr. Hafsa.
I want to ask that if a child is greater than 6 years and he is having severe asthma attack, like silent chest or retractions or respiratory rate is high, then what should be, and he's not responding to 6-puff salbutamol, then we should we add ipratropium or we should improve him, step him to 12-puff?
Okay, good question. So her question from Dr. Hafsa is, so how is going your duties, doctor? I heard, you are also giving duties in COVID, right? I remember.
Yes, yes, I had.
How's situation in Pakistan currently?
Yes, in Pakistan.
No, I mean, how's the situation? I know how many number of cases now there in total?
Almost 20,000 crossed.
Oh, okay, it's getting better. Okay, I hope so. Like all these Asian countries will be fine soon. Yes, let's just hope. Okay,
Yes.
let's focus and let's go back to the inquiry. So, doctor, inquiry was if the age is 6 years or
More than
over.
6 years.
More than 6 years. Okay, more than 6 years. Then initially we started with 6-puff. Then basically what to do next? Isn't it that question? So
Yes, if the child is having severe asthma attack.
If the child is having asthma attack, okay. Yes, all this we applied with help of a spacer actually. The path I'm talking about, we use spacer and these things. So the startup, they will be giving you in the question. The startup, they tried with 6-puff, if more than 6 years, acute asthma attack. So initially it is always asked to use the spacer. So in this case, you go for the 12-puff. So because it is more than 6 years, so you go for the 12-puff one would be better. 12-puff salbutamol. Yes. According to the RCH guideline, let me show you that reference I showed last day. Maybe that can be helpful again. Just give me a second. Yeah. So if you remember, like RCH guideline, I told if 6-puff less than 6 years, 12-puff is more than 6 years. RCH guideline. RCH.
I understand this, but I just want to confirm that if the child is having severe asthma attack, like if there is silent chest or something, as John Mutak says, we should add ipratropium.
Now, that is depending if it is not responding to this, like, this particular thing does not take that much time. If it is the silent chest and thing, when you will do this kind of thing and it is not responding, in that case, you should level up that everything. You should level up everything. All right. So this is one of the thing. But yes, like if it is acute severe asthma or life-threatening asthma, we might need a little bit thing extra here actually. If you see even
Okay.
silent chest, wheeze may be absent, if there is poor air entry, like if typical things are there, in that case, maybe you can consider some other emergency thing if offered in the question. The last question, which we saw, it was not offered to us actually.
Okay.
That was
Yes.
one of the
Yes.
things.
Yes.
Yes.
Yes. You are
So
right.
they have to offer us the thing. So actually, it was not offered because they want to know the stepwise management first. If offered, you will take the better one actually in that case. So that is one of the
Okay.
thing you can do in this case. Yes. Yes.
Thank you, doctor.
Thank you. Yes. Anyone have any question?
நம்பர் அமைச்சிருக்காரு.
No, acid base we're not getting into. It is complicated thing. As I mentioned, acid base will give you video links and also a special session. We might, okay, Dr. Sharia for just raising hand. Acid base is a separate thing, okay? Like somehow it came over here actually, but acid base, I think better we need to make you understand first and then bring the questions actually. Yes, Dr. Sharia, like,
Yeah, sure, Doctor. Actually, in empyema, in that question, that they said that antibiotic is not working for 3-week pneumonia. So
Yes.
in case of empyema, and antibiotic supposed to work, so it doesn't make sense to select the aspiration pneumonia over the empyema in the cases where the antibiotic doesn't work.
Actually, thing is, we might need a little bit more information, like,
Yeah.
example, like aspiration, like we are expecting some, hospital stay more, or patient had gone through hospital, or he was a visitor. So what I felt something was missing in that one.
Yeah, that's for
normally
sure.
aspiration, it can be like, according to like, something which is not responding to it. But if you think normally there could be many reasons. It can be a drug resistant case. It can be certain issues, and the severity of the infection is more. There could be many reasons why antibiotic is not working actually.
Working.
So so certain thing maybe missing in that question. So if we have that one or that X-ray, especially another option was there, the X-ray. Is it the lower lobe or is the upper lobe, or what is the actual X-rays? When we have that X-ray, we'll get idea. Then maybe you can answer more properly in that case. Yes.
Okay. Thank you, doctor.
Yeah. Some of the cases actually, when the question is a bit incomplete, we just know the pros and the cons actually. Okay, if that question is coming in this left side, we will answer accordingly that. If the answer is coming on the right side, we will according to answer like that. Yes. Yeah. Some of the question would be little contra actually. Unfortunately, that's why they recall actually. Yeah. All right. So we can move forward, my dear doctors. Like, yes, I think the time is over. I think most of the doctors are here, I guess so. Okay, so I'll go a little fast now because these questions I expect all my dear doctors to answer very nicely now. All right, so this is the thing. So expecting there will be a lot of rush in the boxes. Okay, let's go and start this case. Now, just give me a second to start. Okay, now if you see this one, doctors like very quick answer expected. 8 years child came for asthma every month for last 12 months. It takes inhalation salbutamol. What to use for prevention? So doctors, it's a question related to preventer. 8 years means more than 6 definitely, or 5, whatever you say. So what do you think is a better answer here? So some of you are answering B, some could be answering C. Now I will reveal soon which one is a better answer here. Now my better answer here in this case, C. Okay, now let me tell you why. See, when we use this one, I mean like ICS, fluticasone means what? These are ICS. Now, when you use the ICS, do you leave the salbutamol? Now, my first question is coming like that. Because you have offered, so just the trick, guys, like exam will just make tricks. Okay, so it is just trick. Your concept is fine. Inhalated fluticasone when you say it. Why inhalation corticosteroid? Because the patient is more than 5 years. So there won't be that kind of growth retardation. Below 5 years, we usually, in some cases, we suggest not to use ICS. Steroid might have hampered the growth retardation. So this is one of the things. So C is a very nice answer. Okay, and so you can check that one from, please take the notes for the first question, like 934, John Murtagi will see, and also you can check the RCH guideline. All right. Okay. So the best answer here is C. Next question. Okay, sorry. Next one. No, it is C. Sure answer is C. It is he's already in salbutamol, means when you are prescribing means what you are leaving in that. Okay, so just exam trick. Okay, there's nothing about argument or something. So salbutamol, you also how do you write the prescription? Do you leave the salbutamol, or you write you also continue the previous salbutamol plus the ICS, the fluticasone. So that plus they are trying to mean here. Also, you might need to adjust the salbutamol as well. That's also their possibility. All right, so you need to think both together. All right, it's just a trick. This is just a word trick. Don't worry, you're not wrong. It's just a word trick actually. You think again in cool brain, you'll understand. A 3-year-old child came with the asthmatic every month for last 12 months. It takes inhalant. This I know very well. This question is what I'm going. I have researched it many times, so don't worry about that one. So this is just 3 years. You see the asthmatic every last 12 months, every month. What do you think? Now it is stepwise asthma management. Do you think the asthma is controlled? My first question, do you think is the asthma is controlled? The answer is, first of all, is probably no, because every month having attack. Okay, and he takes inhalated salbutamol. What to use for prevention? Very obviously, nicely given, fluticasone and all this thing, inhalated salbutamol, and fluticasone. Okay, what do you think? What could be the best answer? What could have been the best answer? The best answer in this case could have been SCG, isn't it? The best answer could have been SCG. What is SCG? Sodium chromoglycate. According to John Murtagh, they have mentioned like the earlier age group, sodium chromoglycate is a better preventer. All right. So this is one of the things. So, but I also told in the theory class that if that one is not present in the option, I repeat, if not present in the option, in that case, we can go for the yes, I mean the fluticasone in that case. Yes. Next answer. Next one. Child with history of asthma was a known case of nut allergy. Both parents are smoker. Now developed wheeze, hoarseness of voice, and other chest symptoms relieved by salbutamol. What is the most likely preventive measure? Such subsequent episode. Now you have 4 options. Very quick answer expected. So in that case, number 1, always prevent from smoking. Those of you are answering not no, like prevent smoker. I wish you would have know about the MC clinical. Whenever we finish any MC clinical case for a kid's case, we tell that one, if anyone in your family is smoking, please try to quit it. Anyone in your family. It can be a grandfather, it can be father, it can be anyone. So it is so important thing in this case. So B is 100% short answer in this case. Next question. All right. So in this one, we are choosing the B. Those are doubtful, I'll tell you. Those are I'm 100% sure I'll tell you as well. Okay, don't worry. Best preventer in a 4-year boy as measured by salbutamol. What's next? So doctors are answering in the Zoom chat box. Very clear cut answer. Preventer less than 5 years, salbutamol. Okay, so they ask what to give next. So going for the correct answer now. I think I think there could be a correction. Asthma not relieved. I think there'd be a word, because if asthma relieved by salbutamol. Okay, if I just make that one in that way, if asthma relieved by salbutamol, okay, like he is not supposed to come then. But do you know, even salbutamol you can adjust, actually you can increase the dose and this kind of thing. But anyways, I think like not relieved by salbutamol, and what to do, I think the typical one, I mean sodium chromoglycate. And remember one thing, sodium chromoglycate can be used as the inhalation form. References: John Murtagh 7th edition asthma chapter, reference RCH guideline. Okay, now another one is coming. I will try to show you at least the similar patterns. Actually, not all questions, like there could be similar pattern, many questions which I brought here, but I'll try to show all the similar pattern. Okay, so 5 year as severe asthmatic hospital, nebulous salbutamol oral steroid, and 1 discharge. Now you remember 1 discharge. Okay, someone said answer not clear, and answer is sodium chromate. 4 year not really. Those doctor is telling not clear. I mean, didn't listen. Like I know Dr. Firoza and few, I think some of them like maybe didn't study the theory well. Now asthma, which is not relieved by salbutamol, and asking about the next one below 5 years. So below 5 year, a drug when it is not controlled, you can go for the sodium chromoglycate. That's very nice, obvious. Okay, let's focus on that one. We don't have that time, guys. Like you have to focus. It's not like ABCD. I will tell in that way. It is the 3rd class in the respiratory, so we have to increase the speed a little bit, actually, dear doctors. Okay, not everyone is same, because you see the others doctors are answering very well. Okay, so 5 year symptoms: severe asthma, admit to hospital, nebulized salbutamol, and take oral steroid. And 1 discharge. I think last day I told a drug that must have to be present when taking discharge, and I think just admitted. So I think not past 5 days. So if it's less than 5 days, I think so in just 2 days and 3 days they want discharge. Oral prednisolone must has to be present. I also talk about a storyline another day of a big brother when we are attending the respiratory, I think courses in one of the institution. So that story, I hope so you remember, guys. So oral steroid is a drug that must has to be present and has to complete the dose. It's a lifesaver. All right, next one. 3-year boy with recurrent attack of asthma and asking about best preventer. So 3-year recurrent asthma attack and asking best preventer. Without any doubt, answer is sodium chromoglycate. Without any doubt, sodium chromoglycate. Next question. 3-year-old, the child comes with complaint of cough, mother had hay fever, and father is smoker. What drug is used to prevent the asthma case here? Question number 7. Three-year kid. And in the option, sodium chromoglycate. See, same question, they're just changing. So same type of question, they're just changing the pattern. Okay, let me show you this thing. Yeah, so again, sodium chromoglycate, this one. Again, sodium chromoglycate. Question number 8, next one, you will find the similar question. Now I will tell you, will not waste your time. Some of the questions are quite similar, you will find now. One drug as a preventive and inhalation before, I think 6 year, I think, or 5-year age. Again, sodium chromoglycate. So remember last day's class, a drug preventer can be inhalation, that can be used in inhalation mode, is also sodium chromoglycate. So sodium chromoglycate can be an answer. Okay, now next one. So these are repeat type of question. Now next one is coming, exercise, something word mentioned, child who has wheeze and cough at night and during exercise given salbutamol fluticasone, best preventer. Now this is some of the update we have shown you earlier. In exercise induced asthma, What is the best preventer? I repeat, exercise induced asthma. See, LABA was also given in John Murtagh, but I should show something from the RACGP, right? Exercise induced asthma. Yeah, this was the reference from the exercise induced asthma. Exercise induced asthma is best managed by inhalation, short acting drug. Exercise induced asthma best managed by inhalation, short acting drug. So it was given in RSAGMA. It's like in asthma book, actually. It is called asthma guideline book, and the very recent one. Okay, so this one is much correct answer. Okay. Now this one to follow. Like when asked best, still this one actually. When you said LABA, it has to be with a combination. Yes, if it's LABA with combination, it's good. But you know, solo, I think the SABA is better actually. LABA, long acting one. Example, salmeterol is a LABA. And salmeterol is better acting when it is used with SABA. Yes, stepwise, very well done. Stepwise management. Next one, I think similar type of question. Next few of them are similar. Okay, so this one, you know, we have a correction here, a new upgrade, that is SABA. Okay, so best preventer is SABA. Previously, we also used to say LABA actually. Okay, but the new update came with the SABA actually. And one of the common mistake, let me tell you, by doctors, they often forget the name of what are the SABA and what are the LABA. Okay, so you just Google it, you will find some charts. What are the name of the SABA? What are the name of the LABA? So these are something you should remember. Next one is coming is an interesting question. A 50-year-old man presented with hypertension. I repeat, 50-year-old man presented with hypertension and asthma and reflux nephropathy. Maybe the reflux nephropathy was diagnosed long back. His kidney function is also not going well. I can see the high creatinine, proteinuria, so definitely kidney affected. What is the choice of antihypertensive here? Whenever there is proteinuria, I repeat, whenever there is proteinuria present and hypertension present, obviously two drugs are choice. What are those two drugs? Those two drugs were, I repeat, those two drugs were AC inhibitor and ARB. AC inhibitor, ARB, both are good actually. Now some doctor also sometimes say that, now I'll put some controversy here. Okay, there was a chart I show you last day, if you remember. In that chart it was also shown that AC inhibitor can also lead to, repeat, AC inhibitor can also lead to asthma attack, like, you know, it was mentioned, but it's not so common actually. It's not like we don't use it. We if you ask me, like, you know, yes, we use it as an inhibitor, and dry cough is a problem. So if something we are thinking in that way, ARB can be better. In that way, ARB can be a better answer. Like if you think AC we should not give, it can cause dry cough, or it might have some connection with aggravating of asthma. In that case, maybe ARB can be a better answer. And which one in the following is the ARB, do you think? In that case, losartan, I think. So still I haven't changed the answer. Let's go for the answer. Still in that one, still I haven't changed the answer yet. Like, see, this type of cases. Also there was reflux nephropathy. Another thing you need to consider, reflux nephropathy is also a thing. So in reflux nephropathy, when it is said, AC inhibitor, ARB also there, antihypertensive. In case of proteinuria also, it's a good drug. But according to that chart last day I uploaded, in that chart it was shown that what, you know, there was a like 8 or 9 drug AC inhibitor name was there. So from that note, if you consider, even in that case, losartan can be an option. So I'll put it to you. Both answers can be correct actually. Still, I haven't gone to low certain before 100% sure, because protocol is still said we start with the AC. Most cases we start with AC. Yes. Yeah. So answer, why not calcium channel blocker? Like you tell better why calcium channel blocker to use actually. There is AC inhibitor, there is proteinuria. Why to use calcium channel blocker? Okay, please do some more research on antihypertensive. You will understand actually that proteinuria cases, it has to be a C or ARB first of all. Okay, in any way, that's the thing. All right, no worries. Okay, yeah. So that is one of the word is coming. If you find some very good reference, I just show a chart. But if you find a very good reference that AC inhibitor is aggravating asthma, then I think go to the low certain actually. Okay? All right. Let's not waste time, guys. Here. Next one. Okay. 5-year boy presented to ER for asthma. I think similar kind of question. So let's not waste time. Just go for answer. Answer is B. Just pick up the answer B. Similar type of question. Let's not waste time. Question number 12, just mark it as B. It is an inappropriate question. Question number B, it was just an inappropriate question. Okay, so you will find it, the question is quite an incomplete one. So just mark it as B. There's no way, we do this one. It's an incomplete question. This one, 12 one. Okay, 13 one, we can see a little bit different. 6-year patient with asthma attack, intake of salbutamol, but no preventer. He's not present with noisy breathing, but mild fever and hoarseness of voice is present. What is the cause of acute asthma? Actually, better to say, what is the cause of this acute attack? What do you think? Not presented with noisy breathing. If not presented with noisy breathing, it probably they're mentioning it's not croup. Croup is one of the conditions which is associated with noisy breathing. But it's mild fever and voice is affected at the same time. So I think what is the cause? Acute asthma, anaphylaxis, upper respiratory obstruction. So there are a few controversies. So I just put it like that. In this one is a wrong question. This is an inappropriate question. This question is not complete. You can give a cross for this question. Because if your stems and this one is nowhere is matching. So some of the question you will find like that. I'm just trying to save your time. In some places, you don't need to waste time because there were two incomplete. So this is one of the question like that. I also try to see pros, cons. Rather, I just recommend you to read John Monta 1070, some of the pages like bronchiolitis, croup, epiglottitis. Those things will be taught in the child section. All right. One of the questions coming is a nice question. Like, see, I'm trying to follow at least one of the pattern of a different one. Stratus asthmaticus. What is that? One is stratus epilepticus. One is stratus asthmaticus. Any difference? Epilepticus, in between the seizure interval, there is persistently seizure happening. Stratus epilepticus. Stratus asthmaticus, acute severe asthma, life-threatening asthma. Stratus asthma which can threaten your life. Acute severe asthma. Remember last day, what are the parameter of acute severe asthma? Okay, some doctor quickly forgot thing. We have to remind them again. This thing, has to be very, very clear. Okay, just give me 1 second. Yes, now it's working. Yeah. So acute severe asthma. Acute severe asthma, more dangerous condition, life-threatening asthma. How do I know near fatal asthma? Or how do you know the patient need ventilation? When the patient's partial pressure of carbon dioxide will be increasing, the patient need mechanical ventilation. So that is a very cool question. Indication of mechanical ventilation in asthma patient. Okay, you will find this option, raise partial pressure of carbon dioxide. Indication for hospitalization, like an inability to complete sentence in one breath. This is very common. So this is important. And then heart rate, respiratory rate, if these parameters are higher or life-threatening, these are the pattern. Okay. So these are the certain thing. These are the certain things, my dear doctors. A known case of asthma patient presented to ER, like his status asthmaticus, and before arrival to hospital took salbutamol inhaler. Very obvious, he took salbutamol before coming to hospital, didn't improve his condition. What to give next to save this patient? So one thing you see, we choose B as an answer. Zina guideline, one of the level evidence, steroid, IV and oral of equal efficacy. So from the Davidson medicine, if you see life-threatening asthma, if you see this one, after high flow oxygen and this thing, it is very, very important. Either you give oral prednisolone orally or hydrocortisone IV 200. So obviously we do have this one, oral corticosteroid. So B is the correct answer for us. Clear? So oral corticosteroid. So here is the evidence from Davidson medicine. Fantastic. This one I think is a question related to different chapter. Just mark this on hemoglobin A1C. This one just came from by slipping from another chapter. You just mark this one, hemoglobin A1C. It's not related to this one. Okay, so we have a bigger question here. So 8-year boy brought to the emergency department because of wheezing. According to the patient, the child has asthma. Use this inhaler at home when he was wheezing. Actually, the original question looks like this. Okay, this one I just brought for practice. This one was not a recall actually. I just brought for practice. The last one. He has been coughing frequently and vomited. Examination shows he has diffuse wheezing. And the breath sound on the both side, decreased breath sound in both sides. Prefers sit up and pulse is high. Okay, you can see blood pressure is this, temperature is this, pulse oximeter shows. SAT is dropping. Saturation is sometimes we call SATs actually, and which of the following is the most appropriate first step in the management? So after so many, nice essay and this thing, they ask this thing. Now there is a trick. Normally I see a question. Okay, 8-year boy, quick scanning like IELTS or any of the exam. 8 years boy. Okay, talking about emergency, I just try to find words. Okay, something wheezing, SATs, okay, dropping, okay, like asking management and the option. I quickly guess, I am quickly got the idea what is my question is about, and I'm getting that information in 10 seconds. So some people start like it takes a lot of time rather than okay, 8 years, okay, wheezing I can see, SATs dropping I can see, and they're asking about the initial and giving okay, this is something respiratory question, because main exam they'll not tell you it is a respiratory related question, GIT related question, but if you can guess it is a respiratory, it's for your brain, it will be easy to answer that question. Now let's go for this one, like what do you think as a first step of management? So they will always try to confuse you in this type of question. Most appropriate first step in the management. It's very simple unless we make it complicated. It is very simple unless yes. So answer is oxygen by mask. Very simple. You need to give oxygen. Very simple thing. Very, very simple thing. You need to give oxygen. Why to give salbutamol? That will come later. Second, you give oxygen. Very simple. Normally oxygen not offered because after initial resuscitation that word is used sometimes. Okay, so normally you will find a question like that after initial resuscitation. That means during resuscitation, oxygen and these things are given. So this is one of the trick. Maybe some of you didn't follow it here actually. Well done. So so E is the answer here. is something. Some of the similar type. I'll just tell you the answers now because we need to move to the next one. This one type of picture type question can be given, and this one is neurofibromatosis. And you can see from the question, it's cafe au lait spot actually. It's cafe au lait spot actually. One of the information extra, asthma cases might have 25% related to nasal polyp. So 19 just put as cafe au lait spot. So worsening asthma and the rash and some of the neurological finding, it can be cafe au lait spot actually. All right. So this is an uncommon question. And another similar type of question, sodium chromoglycate, answer is B again similar type. And this is done with the asthma thing. Now I would like to ask my dear doctors. Okay, yes, it was allowed anyone else to ask anything here regarding the asthma, or I hope so it was clear. I think the asthma, like these are all set to go actually. So we've done the 2000 things, we've done the 2019 and 2018, all were included here actually. Okay, these are the maximum types. Those are, you know, tested in MC. Okay, so new one I also brought at the same time, the common one that has been done. And now your job is to keep checking the Shari's MC guideline group if there is any new thing came up actually. That's how if you proceed, it gives time, definitely will pass. Most doctor from our academy, they always pass. Like, you know, 97% passing rate, maintaining is not so easy unless putting pressure. Okay. So, you know, so very, very important. I'm telling again, technique wise, I'm using quite a superior technique, but the thing it's very, very important. Are you studying enough actually? Especially this thing I'm always telling in the classes, you know, many times I'll be showing this one, rule of 5. Study 5 hours a day, study 5 days a week. Make sure it is 24 hours a week and study for 5 months properly with us. Definitely you will succeed. Yes. And also, you know, some doctors are given rules to see, like, so this is the panel, like, you know, for MC, MCQ, clinical panel is different, other panel is different. During attending classes, I've always found some doctors are with lab. Like from the checklist, I can tell you how many of you are using laptop and tab because the name also came up. Okay. Along with your name, tab, or which device, those name also came up here actually. So please, for God's sake, do not use it regularly. If you're in a duty someday, that's a different issue. But try to get the maximum. You're wasting and investing your time, so give your best. So simple laptop device, headphone, these are important. And Windows and this thing has to be installed. I think it's already did. Some doctors sometimes give my doctor, I can't open the PDF file. The reason is, you know, you don't have the PDF reader. This is a basic thing. You can ask your husband, or you can ask your brother, you can ask anyone, a friend, who can just install the PDF reader if you can't actually. Okay. John Murtag hard copy mandatory for our classes, as you know, and class and things are also conducted by Zoom and all these things. And I myself usually available for any kind of inquiries Friday 2 to 6 p.m. Sydney time, and BD time is this. Mr. Khalid is available in the office like every day 2 to 8 Sydney time he is available, or Bangladesh time 10 to 5 he is available in the office except for Saturday. So you should know all these things, good teaching panel thing. I hope so we'll have a good information things. And yes, notes material, supplying outside, it is not allowed actually, one of the things. Okay, and it's a we are interaction is going on over the text. We can also ask during the classes. After class, if there is any problem, definitely you should ask when I give you that time actually. All right. Okay. One more information. Like some doctors, doctor, why is the link now? 1 hour before class, do not expect I will upload the link of the class. So 15 minutes or 10 minutes before class, expect to have the link. Okay. Just wait for a few minutes. In that case, you will find the link of the Zoom in the group actually. All the best. So this is one of the information I wanted to say. Exam information. Exam will be taken on next Sunday after the class. I will upload a question. I will give you demonstration on the Sunday how to take the exam. But be prepared for the Sunday for respiratory exam. Right? These are the information. Any questions, my dear doctors? Now we can move to the next one. Is it okay if I move to some of the nice questions related to pneumonia? Everyone clear? If you say yes, go on, then I can go. Okay, let me show my face now. Okay. Okay, all good. Okay, perfect. Yes. You have to be excited, for taking classes, very tough. Your back hurt, neck hurt, everything happens. And you can understand, I'm not in the perfect place. Normally, I have good mics in the studio and well set up. But, no matter whatever happened, our doctor life is somewhere like that. Okay, that's the thing. You will be given time later. Okay, the time is open now actually. Okay, again we'll give you time actually. Yes, when time given, then that time try to ask. Okay. Okay, so after pneumonia, I'll give you another session. That time ask that question. Okay, no problem. Next one is coming is a pneumonia. Let's go and hit the pneumonia quickly. A patient is having pneumonia. Okay, by the way, doctors, like they will never tell you this patient has pneumonia. They will tell you patient is having cough, patient is having high fever, patient has these things actually. This question is little uncommon and is a different question, somehow slipped over here, but it's okay to know. His hip muscles are weak and CT showing the spiral stenosis. All right. So he is on statin, like for hyperlipidemia is given. On examination, knee is absent, knee jerk is absent, lower limb is power is 3/5, dorsal spread is pulses and sensation over the thigh is lost. Next investigation is asked actually. Okay, this is a little different question actually, somehow a bit neurological question, but somehow it came over here. But let us try at least to answer this one. Okay, I'll not waste time in this one because it is probably a little new from some of you. Okay, in this one, basically I wanted to say this question, when we said spinal stenosis, so they might give you a CT scan and CT will be showing spinal stenosis. So the disc and that part and that would be narrow. I'll show you someday that one in neurology. So you'll get to know it's in stenosis. Now, what could be the cause of stenosis? Have you heard about vascular claudication? Anyone? Anyone heard about vascular claudication, my dear doctors? Like this one, claudication. What does it mean? When you walk, you feel pain. I repeat, when you walk, you feel pain. That is the claudication thing. Now you need to understand, is this pain is because of you are having neurological problem, or is this because your organ, that is why I mean the leg, is not getting enough blood supply? I mean the ischemia thing. So some of you said directly ischemia, agreed, but it can be because of neurological. Now the neurological claudication, that can be spinal canal stenosis. And there's another one, aortic, and this one. All right. Now there's some differentiating point which I will teach you in the surgery more on that one. One of the very common thing, like if you see against the gravity walking, when we climb the stairs, we feel some discomfort compared to when we come down actually, but we don't feel pain in the leg. But in case of vascular claudication, what do you expect? And that term is called uphill. I repeat, that term is called uphill. So when you are going uphill in vascular claudication, do you think the pain would be there? What do you think? Answer is surely yes. But while you are going down, do you think pain will be there in case of vascular claudication? Because it is towards the gravity. So coming down through the stairs, you will not feel that pain, but going up with the stairs, you will feel pain. That is vascular claudication. Now, neurogenic claudication, no matter you climb stairs or you go down, you will always feel the pain because it is because of the nerve, the stenosis. That is the thing. So this is one of the parameter, and also neurogenic also have bowel and bladder related symptoms, which vascular probably does not. And neurogenic claudication, you need MRI. Vascular claudication, you need duplex ultrasound. Now, coming back to this question in the CT it is said spinal stenosis, isn't it? Spinal stenosis. At the same time, it is solved mention the pedis pulse is lost. So when it is said pulse is lost, let's just see the pulse. What does it indicate? You are not getting enough pulsation. Is it a vascular problem or is it a neurological problem? So if you see here, you will find that one. Peripheral pulses. You see this one? Peripheral pulses. Okay. So that can be affected. Peripheral pulses. Okay. So this is one of the things. This is one of the things. So that brings us to a point. It can be a mixed variety. Just an idea. That brings us to a point. It can be a mixed variety. So in any way, neurogenic claudication, we go for MRI, vascular claudication, duplex, mixed case, duplex initially. Okay, so this is the thing, because vascular is probably even more emergency sometimes. Actually, depends. Actually, both are emergency, to be honest. So let's do the duplex in case of also mixed variety. Actually, so this is a little complicated question, my dear doctor. So which you can think in that way: neurogenic MRI, vascular, duplex, mixed case, duplex. So this case was a CT showing stenosis, some scenario showing vascular. So we go for this one. Let's not waste time. That was not a typical question of pneumonia. Now let's get into the typical questions of the pneumonia, and also somewhere this one, let's not take time. A lady with pneumonia symptom and she's oriented and stable. GP suggests admission in hospital. She refused and asked medication. What he will do? Some of the ethical thing is coming. She refused and asked for medication, but she is oriented and doctor suggested to hospitalization. Now what to do? So in this case, these are silly questions, but these are important. Counsel her why this admission is necessary. Counsel her why it is necessary. Yes. All right. Very simple. See. Next one. A child 3 to 4 years with a fever like this, cough like this. So fever, cough, child. Okay. Pneumonia probably would think. And for unwell for 3 days and wheeze and but minimum lungulation. Chest X-ray given a pleural effusion, investigation for further assisting a diagnosis. So what investigation to do for further assisting a diagnosis? Any idea? So giving you a few seconds to answer this question. So in this type of case, yes, see, whenever a kid with fever, pneumonia, or whatever, septicemia, sepsis, like any type of feature are there, you should come up with blood culture. So all of you are correct. I'll not waste time here. So I'll go for the blood culture here. It's correct. So since most of you answer correctly, I'll not going too much explanation for this one. But the explanation is when a kid is presented with high fever, there's suspicion of some certain thing. In that case, definitely blood culture should be. Yes, talking about the X-ray already here it is done. X-ray already here it is done. So the obvious reason you need to know the what organism causing it. You need to go with the blood culture. Very simple thing. Check the John Murtagh 7th edition, that cough chapter. John Murtagh 7th edition cough chapter. It was given there. Next one. I think kind of similar question. Child with fever and cough. Lung signs are normal. X-ray showing left pleural effusion. By the way, pleural effusion can be exudative, and exudative it can be pneumonia, right? Okay. Next management that is asked. So when again the same thing, next management thing that is asked. Again, blood culture. Again, we like to go with the blood culture. Very simple. Next one. Next one is a very cool and different question. In Australia, which of the following is the most frequent cause of death in previously well 3 years old? Now, many people made mistake. I want only new doctors to answer this one. If anyone is in the revision phase, try to hold yourself for a second because you know the answer. So many will answer this one A, many will answer as D, many will answer as E. So all looks like answer, but which one is the real answer? Now, very, very interesting. in this case, let me first tell you the main answer. Main answer is drowning. Talking about the Australia actually, Australia, which includes the regular people, Australia also includes the Aboriginal people. So in Aboriginal, obviously it's more the number of death. But in Australia, if you see, even in winter, now it's getting colder here, even the full winter, last time I came also it was winter. So I found like, even in the beach side, there are few people, they're wearing jacket and, they're after the sea. Nothing can stop them. Have you seen this kind of people? I think it's very common, here actually. They want water in any way. And there's high chance, the drowning can be possible and things. Yeah, even though they're good swimmer, but they're, the rocks, there's a lot of things. So it's not always 100% safe, even though they're good swimmers. So drowning always remains most frequent cause of death among the listed. Now, contradiction with the sudden infant death syndrome, which is also a very common one. It is common one you see up to the age of 12, but by the 3 years, it is rare. So SIDS is common by 1 year. The same question, if I just tell in 6-month kid, what would be the answer? If I say 6-month kid, the answer would be SIDS. Now, my question is 3 years, so it is obviously answer is changing into drowning. Now, if I say 40-year person in Australia, in this age group, what is the most common cause of death? Or in adult, what is the most common cause of death? That is again an AMC question. So what do you think, doctors? The answer is road traffic accident. No. Why leukemia would be? Road traffic accident. No, I told about adult. Adult, most common cause of, like death. Actually. Elderly, that would be different. Elderly, again, that would be different. With the adults, I think road traffic accident here. Motor vehicle accident, someone said is also correct. I hope so it's clear. But it's a unique type of question. This type of questions are called, guys, population health type question. Now, sometime you might be seeing in the mark distribution. There is a nice thing it's given in my YouTube channel. If you see, like the mark distribution, so that one things are mentioned in nice way. Okay, so you can see the mark distribution again there actually. Like, so there's another option for population health. So population health, this is a typical population health type question. Next one is coming, child with 7 years old, and this is the fever and lethargic and grunting. Remember last day I told, if grunting is there, this condition is not good. Okay, on examination, the chest is clear, but the grunting is present. So what do you think? There is fever and there is grunting. So this is, I think, clear again. This is a case of diagnosis here is pneumonia. Why did you learn that word grunting and the fever and these things? Yes, it was that pneumonia case. Okay, some doctor has a dilemma, doctor, when we learn the group epiglottitis, bronchiolitis, doctors will learn that 3 important things in pediatric cases. Right? That is one of the things. But if those are more interested, you can go to the John Murtagh 1071 pages. Next one question. Child with 3 to 4 years and fever with this and history of cough unwell for 3 days. So see, typical pneumonia, it is given 3 days. That was I was telling, another question which I saw in pneumonia versus emphysema. That's why I was thinking that question could be also pneumonia. I mean that emphysema, because most of the pneumonia questions are within 7 days it's given. Okay, I think he was wheezing but minimal lung sign on the X-ray given. Asked which investigation would you do for further assisting the diagnosis? Okay, blood culture is not given in the option. Then which one here? One of them is also common, like in case of investigation. So in this one, we like to go with, what do you think? Pneumococcal antigen. The name given, blood for pneumococcal antigen. Simple test. So this is like, not a problem. You can just make the diagnosis. Like, if you just go to the cough chapter, John Murtagh, you will find this answer in the pneumonia, pneumococcal antigen. Also, you can check in Davidson. Yes. Oh, I don't have doubts. So no worries. Yeah, someone is asking. Okay. Next one, doctors. Yeah, this is a tricky question. Often it hampers our some of the like typical question. Waldenstrom macroglobulinemia. Unfortunately, it came over here. It's not a question related to here. Okay, past history given of chicken pox and this thing. Now, history of pneumonia started ampicillin and azithromycin after next day and developed rash over the abdomen. Now, patient having rash and Waldenstrom macroglobulinemia, like those doctors don't know. I think most doctors don't know what is Waldenstrom. So Waldenstrom is basically, if you see, malignant B cell. It is somewhere we are taking this thing to hematology, overproduction of malignant B cell. What cell? Malignant B cell. This is one of the things. Waldenstrom macroglobulinemia. Okay, so you see a few things: plasmapheresis, the blood changing thing, that is a initial therapy, and this is also, since it's a malignant B cell, it's a cancer, so you need also to give chemotherapy and also prednisolone here. But the question might be often coming regarding the investigation. So in terms of the investigation, if you see the Waldenstrom from another book, I found it. Apart from ESR, LDH, these are very common thing. It is done in case of cancers. Yes, so bone marrow biopsy, guys, bone marrow biopsy that is given here. Someone please take a snap, please, this one, and this could be useful later for preparation. So bone marrow, that biopsy can be important. I'm holding here for 5-10 seconds so that you can take a snap and prepare this one for later. But it's a useful one, and reference is given, bone marrow biopsy. So in this one, I choose also bone marrow biopsy. Do you think it's correct? What do you think, guys? Because in the main one, bone marrow was given. So usually try to get the reference from a book first, then the journals actually. Okay, some people ask me, doctor, journals are better or books are better? Obviously books are better because books made from a lot of journals. All right. Next one, bronchiectasis scenario. See, our bronchiectasis thing just came up here. So bronchiectasis scenario, superimposed pneumonia treatment. So what to do? So this bronchiectasis one, if you see, bronchiectasis scenario, superimposed pneumonia. Unfortunately, the vital is missing, because how to assess the severity, if you remember. To assess the severity, we need the vital actually. If vitally not sound, grunting, this kind of separate words are present, respiratory rate is more than 50, this kind of words are there. In that case, definitely we think about the severe. But if superimposed pneumonia can be a dangerous, so overall, I think this can be a case which is related to bronchiectasis. And bronchiectasis cases, you need to understand one thing: what is the organism? Remember last theory class, bronchiectasis case, bronchiectasis maybe has somewhere related to cystic fibrosis. Now I'm trying to give you a hint. What organism? Is it big three or is it Pseudomonas? Just talking about bronchiectasis. Bronchiectasis have connection of pneumonia. When you have bronchiectasis, it is very common you can have pneumonia anytime. but you need to understand which organism would be common. So bronchiectasis has some connection with the cystic fibrosis type of things or organisms. So I think Pseudomonas. So if it is Pseudomonas, what type of organism is that one? Gram positive or gram negative? And sorry, this is somewhat related to gram negative type of certain thing. And bronchiectasis scenario, superimposed pneumonia. Pneumonia, if superimposed, is never a good sign. So I would say the condition could be quite severe. If the condition could be quite severe and gram negative, I think I like to go with this one. Ticarcillin is something, a drug which can be used for gram negative cases. So this is the little tricky guys. This one was a little tricky. So a bronchiectasis case, how do I understand CT scan bronchiectasis? By checking the abnormal and permanent dilatation of the bronchiole. Abnormal and permanent dilatation of the bronchiole, which even can be visible, like a lot of chronic marking, vascular marking you can see, and also the dilatation you can see. All right, so chest physiotherapy, infection control, these are the main stay. Okay, guys. Give me 3 seconds. Just now we did that one. Now a lot of question that was a similar type. Some of the questions would be quite similar, like pneumonia and certain other type of questions would be quite similar. Like some of this type of questions, like COPD, I'll show you very soon. There will be some of the questions that is related to COPD type. Okay, so that one I would like to show you very soon. Okay, so a lot of some of the question, as I mentioned, can be similar type. As you can see, question number 12. Let me just give you at least the answers quickly so that you can at least check that one. So question number 12, at least I want to show you. That one for me, it's little different because the 65-year and smoker when presented, and there is raised JVP and hepatojugular reflux when it was mentioned. That means what? Left side involved or right side involved? Raised JVP and hepatojugular reflux. Hepatojugular reflux is when you press in the liver area, the jugular vein is even more engorged. So it means somewhere the right side is involved. So the right side is probably involved, and also there is somewhere presentation of respiratory. So there is a heart disease probably due to lung cause. And what heart disease? MI, heart failure, arrhythmia, which one you are expecting? We're expecting heart failure and we're expecting right heart failure. So bilateral basal crepe, isn't that a common feature in heart failure? Answer is yes. So pulmonary edema, which is a sign of heart failure. Secondly, raised GVP, jugular venous, and bilateral that crepitation. So heart failure is there. And at the same time, smoker, so breathing problem, so respiratory problem is also there. So high likely it is a case related to core pulmonary, we strongly believe. Patient high likely having underlying COPD. Patient often have, have you ever heard this thing? COPD patient can develop heart failure. Have you heard things like that? Yes. If yes, which heart failure? Right heart failure. Do remember one thing, when you have one heart failure, another heart can be affected as well in future. So that's the possibility. another extra question that would be useful for AMC prospect. Now, in case of this core pulmonary, okay, or the COPD related problem, is there any pre-existing heart disease you are expected? Pre-existing heart disease. If the answer is yes, is it right-sided heart disease expected? Now I'm getting into little tough level. Some of you might find it a little tough. So sometimes it is better you don't understand something, you take note, later think about that one. So coming to the point, if you have the issue called pulmonary, which sided pre-existing heart problem it is expected? Like, I mean, heart problem means there's a serious issue. So heart problem expected is left-sided. And that is, you see in the right-hand side, pulmonary, I mean mitral stenosis. When you have mitral stenosis, which is a valve from the left side, from left atrium to left ventricle, so that would be affected. So the vasculature in the lung would be also affected because the left atrium affected. As a result, the right side would be affected. So pre-existing problem, mitral stenosis can be a big problem. Yes, mitral regurgitation also it could be, but we have seen the prevalence. Mitral stenosis is more actually here in this case. Mitral stenosis, let's think in that way, and it can lead to this right-sided problem. So these are the points to be remembered. Okay, so this could be an extra point actually. So left-sided problem or mitral stenosis it could be. Please remember that one. And afterwards, this question's answer was D. Afterwards, there was a question. There was a travel related one of the video I was supposed to make actually. So travel, I'm not in getting in, but for a recent travel to Asia after coming cough, fever, 3 days after coming and pain. Okay, so that depends on the X-ray, but high chance it can be in just 3 days. I can't tell it is a tuberculosis. Can we? In just 3 days travel, is it possible to consider TB? I think it is a bit less likely, isn't it? Considering TB. So I think it's better we go with the fungal also takes time. Fungal also takes time. So I think viral pneumonia, I think quickly transmitted after travel. All right. And this one is basically a repeat question. So just give a cross. Yes, this is one of the question I was looking for. Adult girl with no history of chest disease. Anyways, no pre-existing. Actually, no history of chest disease means no pre-existing. Sometimes we have to know the better words, pre-existing condition. Come with pneumonia and oxygen saturation is 85%, but alert. How to give the oxygen? I think we just also finished this one a little while ago. So answer for this one is, what do you think? 85, much less than 92. So 85 or less than 85%, our answer is non-invasive. Non-invasive. So it can be intubation, it can be CPAP. Among the CPAP intubation, I'll choose the CPAP. So C is correct, as like most of you did. C is the correct answer. All right. Well done. So here's the reference. Here is the reference. Maybe you can take a snap and use it later. Excellent. So this one is given here 85 or less non-invasive. So CPAP. Now after some of these are somewhere repeat question, again a Walderstrom question was there. Walderstrom sometimes came as a confusing thing. Sometimes a confusion is there, like what to give as a treatment. Like Waldenstrom can be even aggravated after starting the drug like ampicillin. So in that case, what to do? So any idea? Waldenstrom, typical feature of Waldenstrom. These are some of the tough recall actually. Waldenstrom one always been tough in MC. Started ampicillin after minimal time and vascular rash appeared, asking for management. So what to do? Is it I should go with A or I should go with the C? So in this case, see, drug can be an aggravating factor. I repeat, the drug thing can be an aggravating factor. So since drug can be aggravating factor, we need to cease the drug. From those note I have given you earlier, the note I gave you earlier, it was showing prednisolone was in the treatment option. But do understand the amoxicillin might be an aggravating factor. So in that case, we cease the amoxicillin and then we give the prednisolone. So in this case, I think C can be the answer. So first C, let's stop the one which is causing it. Then we give the prednisolone. It's not like the prednisolone will give next day. We stop the drug first, tell the patient that not take the drug and then start the prednisolone. It's simple, like drug allergy that is aggravating a blood cell related disorder. Very simple. There is rash present if you see. So this condition is aggravating this rash. That's the thing. So stop the offending. Now I'm bringing something to bore you again. Compare and contrast. Okay. Anyone can remember this kind of thing where we need to cease the offending? Anyone from the previous batch? Like cease the offending thing first and then go with the regular treatment. Anyone? Cease offending and then treatment. Anyone from the previous batch? Now it's not new doctor's test. Those are the previous doctor. Now see, like they're not performing well. Okay, so Dr. Angela said hyperkalemia. Okay, hyperkalemia. So yes, good one. Then take it as granted. Hyperkalemia. Someone said COPD. Very lovely one. COPD cases actually, what we do, stop smoking first, and then we go for other hyperkalemia cases. Any drug which is causing hyperkalemia, we need to stop that one first and then go with the calcium gluconate or other treatment. Okay, so compare and contrast. It is important to remember. Okay. Now there is one of them you will find a bit confusing. A patient with a wife to Thailand came back and having dyspnea just after coming back and even altered level of consciousness. Wife is well, by the way. No for this sputum is not a temperature is this. What is the most likely diagnosis? Now you will be confused a bit. Pneumonia, pulmonary embolism. Okay, someone said is a previous one also a very nice one, serotonin syndrome. Actually, I wanted to look forward to that answer. Serotonin syndrome, you withdraw the drug, then you think about the giving the other treatment, like dantrolene or those things later. Okay, serotonin syndrome. Okay, some doctors I think things are going above head. Some doctors have little gap. So not everyone is saying, my dear doctors. So let's help them here a little bit. Don't worry, we'll learn this thing in psychiatry. Don't worry, those are not getting it right now. You'll get it. In serotonin syndrome, a lot of effect happens, autonomic and this type of effects. Okay, a lot of this type of autonomic effect happens because some of the drug given, SSRI plus SNRI or SSRI or tramadol hydrochloride for abdominal pain, and there is aggravation of serotonin syndrome. All right, and you see this one, cyproheptadine is a specific treatment, but first you need to stop the offending, and if two drugs is causing it, you need to stop both two. Now another confusing question comes in exam. They offer stopping one drug and not stopping both. No, your main answer is stopping the both. That is the main answer to remember. Okay, and then going for the cyproheptadine if it's necessary. That's how we would proceed there. Now coming back to this one, as we can see, so his wife is well, and let's not waste time here. Dyspnea, so just came back, so I just make it a little correction. Just after coming back, this is happening. Okay, now one more information is that a very long flight enough to cause deep vein thrombosis? Now first question, from Australia to Thailand, I think 6 or 7 hour journey. Is that included as a very long flight? What do you think? A lot of yes, no. Do you know how many hours time it is left to go to Canada or USA? Then you won't tell that one as that long actually. Yeah. So 14 hours, 16 minimum, and also there is layover sometimes, but at least it takes almost a day to travel to, you know, and even if it is non-stop, at least it will take 15-16 hours. So there are some flight, you know, like Dreamliner and some of the big, you know, very good flight came these days. They can fly, I think, for total directly 15-16 hours. Yeah. So this is the thing. Now I'm talking about the continuous flight probably. So this one, first of all, you know, we are not considering Thailand to Australia very long flight, and no for the sputum thing. So pulmonary embolism is out probably, but we'll keep it in mind. We'll do X-ray and things, and malaria is too early to consider that one. DVT, no mass in the, you know, calf muscle, so that's out. So when we go by exclusion method, it can be the pneumonia. There is temperature. Or someone said no, there is temperature, my dear doctor. Temperature, it is there. So there could be viral pneumonia, the bacterial, viral, the fever might not be that high you are expecting. Okay, so these are the things it can be. So sometimes we have to use exclusion method. All right. So this is we call exclusion. So by exclusion method, we go for the pneumonia. All right. So this is the very, very one of the important thing. Great. Next one is coming up. This one I cross because this one we will cover in. This one just give cross because it's a rheumatology question. Just give a cross here for this one. Raynaud's, you know, some phenomenon and thing, which we will be covering there. Okay. So asthma thing we covered, some of the pneumonia thing which is covered right now. After that, you know, we like to add something. We like to go for one of the case, very, very popular, Just give me a second. Bronchiectasis, we found one case. Waldenstrom, we found one of the popular case. Some of the cases are given at the end. Saturation, we got on question. Core pulmonary, we got one. Okay, mesothelioma, then the lung cancer. These are leftover. Before that, in between, tuberculosis coming. But tuberculosis, one question we got, as I mentioned, dear doctors, tuberculosis, two-way question can come. One, the typical feature of tuberculosis just came from an immigrant country like India, Bangladesh, Pakistan, okay, even Bangkok. So they might bring the tuberculosis. This is one of the typical question. One of the question which was related to latent tuberculosis. Last, if you remember, also today we show that one. It was that latent tuberculosis. I'm showing it again. Okay, why did it? Yes. So this is the one. And in this question, the main issue was to find out whether my patient is symptomatic or whether asymptomatic. If symptomatic, say cough present for 3 weeks, I would say it is symptomatic. If say hemoptysis, I would say it is symptomatic. Okay, so in that case, most cases you'll be given an X-ray thing. The next thing you have to do is sputum to confirm the condition. Now, if your case is asymptomatic, then another hand side. So in that case, we'll try doing more tests. But if it is not successful, right, IgRA and this kind of thing, we can go for a 9-month INH treatment. What is INH? What is INH? Any idea? So INH means isoniazid for 9 months. So INH for isoniazid 9 months. This is one of the important things here. This one you need to consider. INH 9 months. Okay. So before getting into that one, I'll go for taking 1-2 question from my dear doctors. All right. Does anyone have any question you can ask? I don't mind. Okay, I just unmute the mic. You can ask me if there is any question. Thank you. I mean, from the pneumonia section. Yeah. Okay. In terms of the protocol, like one doctor is saying 6 months. In our Davidson and this thing also said 6 months to 9 months. It's given in that way. So see, Davidson is depend on the NICE guideline. Since we are preparing for the AMC, we will follow mostly the John Muttak one actually. Okay? So 9 months, there was a question stem was given like that. Okay, so that's the thing. Okay, anyone have any questions? Someone raised the hand I saw. Anything left over? Okay.
Hello.
All right. Yes, doctor, your voice is very low. Are you in headphone and in laptop device?
Yeah, I'm on headphone. So my question is that when it comes to cause of pneumonia, we know that Streptococcus pneumoniae is the common cause for all age range except for infants.
No, not all age group. That is like, wrong conception for a long time in med school. It's not like that. Strep pneumonia, it's overall except for the neonates, also for certain age groups actually. Okay, so let's make it as a correction. Yes.
Okay, thank you.
Mm-hmm. Yeah, overall, when we think about the adult one, it's okay, like, okay, strep pneumonia, and also it's one of the big three. Also, it's one of the big three. In that way, it's okay. But when it's talking about a kid, mycoplasma, if it's there, you can choose that one always. Okay. Sometimes also some question might came, as I mentioned, one of the question in pneumonia also might come in that way that they will give you more X-ray finding, but the patient presented with only dry cough and low-grade fever. That could be atypical pneumonia as well. And in that case, the treatment can be number 1, azithromycin. Please do not choose the doxycycline I show last day in the class, because 6th edition to 7th edition, so they have changed the doxy into azit, even though nearby, but it's okay. Like they have put the azit up actually. So if you find the both option, azit and doxy, now you have to choose the azithromycin would be better. All right.
So
Any
for,
other question?
so for kids and neonates, mycoplasma is more common.
You please follow. Are you in the group batch 31?
Yeah.
Okay, so I think there was a chart we showed before. Actually, you just follow that chart. You remember the chart, pneumonia?
Yeah. Yeah.
Do you have that chart?
Yes.
Okay, so why don't you just follow that chart? Like your. Let me show you again. That chart. Do you have this one? Okay, so just follow this chart actually. Overall, actually, see overall it's okay. Pneumonia, strep pneumonia, but group wise that's okay actually. All right.
Okay.
Thank you. Not a very intelligent question. Okay. Anyways, anything else, everyone?
Sir, if we get a picture of atypical pneumonia like dry cough and fever, but the question says that the person is alcoholic, then what to choose? Then it would be Klebsiella.
Now it's a very nice question. Very nice question. Alcoholic cases, there was a thing like that. Let me show you that one. Alcoholic cases, there is someone is still fighting the thing. I show you the chart actually. Like it is also universal. Strep pneumoniae overall all thing of pneumonia. Okay, so do not unnecessarily just keep arguing. I am also telling strep pneumonia because we're talking about the adult things. When the adult things are coming, strep pneumonia, that's universal actually. But you also need to understand what are the exceptions actually. Some doctors just hold a line and just keep arguing with that one. It is not like you need to, if you want to pass the MC, you need to know the different the exceptions actually. So example, the infant one. So you're finding the bell as a like more common. It's like group B streptococcus, then E. coli, then listeria, the simple mammonic bell, and the infant one. If we find the respiratory syncytial virus, so should I put the respiratory syncytial in that case, or should I put the streptopneumonia? So unnecessary this argument. Like it's not necessary. Doctor, that who mentioned John Mutak. What's your name actually? Your name is not showing in Zoom actually.
Sir, Dr. Farah.
Doctor?
Farah.
Okay. So you change your laptop thing name. Okay, it's came the name unique actually. Maybe the product actually. Okay, because people need to show. Yeah.
Sir,
So
I'm the one who asked the question.
then why you are again arguing? Then I don't understand.
No, I did not write that thing, sir. The unique. I'm not unique.
Oh, okay. No, I'm who actually the name.
Oh, I did not write it. Sorry.
No, not you. Yeah, that's what I'm saying actually. Yes. Okay, who is that one? Like with the laptop unique. Okay, okay, no problem. You can ask the thing, but it's not about argument. It's just about tricks actually, guys. See, court. If you go, a lawyer can put anything and can put you in trouble. It's not about we're here. We are a team. We will discuss things. Actually, it's not like. So I'll show you some of the references actually. That is universal, but you also need to know the exceptions. Otherwise, there's so many different tricks you are watching here right now. All of them would be invalid. No, doctor, then streptopneumonia. Why not Klebsiella here? Why not streptopneumonia? That is the thing. So this is important to consider here. Okay, just give me a second. Okay, so this one, guys, could be useful for all of you. This one could be useful.
Yes, Dr. Sharia.
Let's take this one. And I'm taking 2-minute break actually. Yes.
Yes, Dr. Sharar. I have one.
Okay, everyone, so let's get started and let's finish up. I'm also tired now because a lot of things have gone through. And the thing, I'll take the questions later. I think because question, it will just get going. Let's come back actually, like, silly things better. We don't bring actually like childish and this kind of thing. Right things will be fine actually, yes. Yeah, we can discuss that one later. I'll make posts, you see, in the groups when I make the inquiry status. That time, we can clear this thing. Let's not waste time here actually. Okay, if there will be inquiry, that will be fine totally. Okay. So is my screen is visible, everyone? Screen and these things are visible, guys? Okay. Please make sure your name is displayed, which is very, very important. Like two of the name is coming user. I'm not sure who are they because sometimes important to understand. Dr. Trudy, you what's your Facebook name, please? Dr. Trudy, you are you using some other's device? Just it's cross-checking. Is my class monitors are present? Just please if you can check with that person. Someone I can see a name TJ Money. I'm not sure the name. Also someone with a big name. Dr. Sharwan, I know. So most of the names are familiar except for the end. Sometimes your name came up. So sometimes due to security reason, you might ask 1-2 times. This kind of thing. Okay. So please make sure one thing that your name is showed in the devices. Like what's your name actually? Especially two name I saw with just user and user. We're not very sure, who are they. Okay. So next, if you don't correct it, you might be removed like due to security reason, but it's today for 2 days. Okay. No problem. Okay, now let's come into this one. I mean, let's not waste time. One of the case what somewhere patient from the Iraq and dry cough and no fever hemoptysis. You notice pansystolic murmur on the apex and X-ray was given. So coming from the Iraq and the dry cough and this thing. So pansystolic murmur on the apex. So this one we solved as tuberculosis, and it's little complex, but one of the article it mentioned like a complicated case of TB that can be presented with murmur, okay, and systolic murmur. Systolic murmur, this is one of the things. So complicated case of TB can be presented with systolic murmur, and here is the reference journal. These are one of the complex question. I'm just making an answer, and I'll share a link in our group later. Okay, so I have a link to share, so I'll share that link. For now, this is the link. Like the journal is this one, like PMC. If you just type PMC 35111-259, so you'll find that journal actually. So it's called the index journal number. Yes. Okay. One more question, which was like, now we are at the end and some of the control things are coming. Patient present with the foul smelling cough and high fever, rigor. X-ray done, nothing mentioned about the finding of X-ray. After giving antibiotic, what is the appropriate investigation leading to diagnosis? Okay. So what do you think about this case? Any idea, guys? A little different question. Waiting for the answers, checking the box actually. Patient presented foul smelling cough and high fever, X-ray done, mentioned about X-ray and giving antibiotic. What is the appropriate investigation to set a diagnosis? So X-ray is nothing mentioned according to the recaller. So X-ray, we use a word, maybe inconclusive. Now, if X-ray given, normally, lung abscesses are sometimes quite clear cut actually. It's possible because, like it would be like fluid and that level thing is there. It's sometimes useful. So I think in this case, I think it would be better if we go with the blood culture. I think that would be a little better. All right, I think I need a little rest. Actually, my voice is also a bit affecting. How about a break? Guys, I think I need a little break here. I think it's very tough. 3 hours shouting. Okay, so I'll go for a little break here. Yeah. Okay, hello, Dr. So I think we can finish the little bit thing that is remaining in another 1 hour session. So I can maybe record that one and upload, or maybe I can tell a session. And some doctor also requested, because they have, I think, study time here, I think, in some countries actually. So I think it's getting too more long, I think, could be. And also, I'm not feeling well actually, because suddenly it was very long class and intense, and we are also broadcasting that one. So I think no, I think I'll the remaining 30 minutes or 1 hour, I will do one thing. I'll record it and I'll upload it. When I'll feel little better, I'll also do, because I was also Ramadan is going, so I was whole day. So it's very tough. Normally it doesn't matter, but after 3 hours, the body start getting little hard actually. Yes. So I'll just upload. Don't worry. I'll announce that one. So that's not a matter actually. So yeah, I'll try to make it as soon as possible, like and make it happen as soon as possible for my dear doctors. And hopefully, yes, I have so the videos on now. So yes, need little rest because they're more than 3 hours tough, but we can do an extra session, and or I can make of my own and upload the remaining. I think 30-35 minutes I left, and I think many doctors are having Ramadan actually, and they need to go for iftar. So I don't want them to have during Ramadan time, they, if they're angry with me, that's not good news for me sometime actually. Doctor is taking class, I'm breaking my fast actually. But do understand, I was also having the Ramadan whole day. So I think so my best wishes, like there was like 30 minutes, 40 minutes. Some of the topic left, like pneumothorax, uh, pulmonary hypertension, one of the similar, sarcoid, and the lung cancer, mesothelioma. So don't worry, maybe 45 minutes to 1 hour. So I will make sure that thing will be covered actually. But the main one was the big number question, pneumonia, asthma. Okay, so those things, and also because we add the 2018 one as well, along with the previous year file actually. So that's how the time came up. So first 1 hour actually, that actually take this time away, because we also add the 2020. It was very latest actually. Okay, so I hope so we will be covering in coming days. Waterstone was also covered, don't worry. And some of the group thing we'll be doing in peds. Pneumothorax, more question will be in surgery. Tuberculosis, we done one thing. Lymphoma, one question was there related to renal transplant. I'll cover it. Saturation, we did. Mesothelioma, one question. So just one. Some of the uncommon but important though, it was left over. So I will cover that one. And but it's better to take when you're fresh. When you don't feel it, it's better not to continue. So I hope so it was useful. Don't worry, and I will make a post in our those are taking our classes. Like those of you have the inquiry, I'll try to give you reference, or I'll try to cover that one actually. Okay, like so that will be useful actually. And the extra 1 hour, as I mentioned, I will record it and upload it. You will get it before the Sunday. There will be exam for all of you. So my best wishes, yes, and have a good day. Thank you so much. Yes, Dr. Jerry.